Dr. Saritha ma'am, Dr. Nishi.
I've joined from my laptop also. I'm not being allowed to unmute from my laptop.
Okay, Shreya, Gauri, just unmute. Dr.
Yes,
Nishi.
sir.
Dr. Nish. Nisha,
Yes.
no?
Hello. Yeah.
Nishi.
Nishi,
Am
yeah.
I audible?
Yes, ma'am, now.
Hello, good evening, everyone. Welcome to this ICOG course in oncology, and thank you so much, Dr. Parag, Dr. Sarita, for giving us the opportunity to conduct this, the day one of this prestigious ICOG oncology webinar. I request now the admin office to have the prayer song to pray. Thank you so much. So I'm Dr. Sarita Shamsundar. I'm the chairperson of the Foxy Gynecological Oncology Committee from 25 to 27. So I now invite Madam Dr. Sunita Tandurwalkar, who is the Foxy president for this year. Madam is
She's just going to join in 5 minutes. I think if Suvarna is there, then maybe you can take Suvarna first.
Doctor. Yeah. So welcome Dr. Suvarna. Dr. Suvarna Satish Khadilkar. She is the Secretary General of Foxy. She is a professor and head of the Department of Obs and Gynae at Bombay Hospital in Mumbai, and she has held various positions in the past. So Dr. Suvarna, please for your message.
Yeah, thank you so much. I hope I am audible. I'm
Yes.
out. That's yeah. So first of all, good afternoon, everyone. And I can see the amount of work the ICOG, team is doing. And I want to congratulate Dr. Parag and Dr. Sarita and the entire ICOG team for having wonderful ICOG certificate courses over the last few months. And this particular course is done by Dr. Sarita, who is our chair of oncology committee of Foxy. And I think when we were actually the young consultants many few years ago, we used to have only general gynecology, and over the years now the gynecology has divided or subspecialized in various other subjects like oncology. We used to do our own oncology when we were in JJ as a lecturer, associate professor. But now we have a highly specialized, we have consultants who are only following oncology in gynecology. So I think it's commendable the depth of the knowledge that all the specialists who can have and who can impart their knowledge to rest of the gynecologists is commendable. And I think I saw the program. I think Sarita, Bhagilakshmi Nayak, and Harshad, all three of them are experts in this specialty. I think they focus more on gynae oncology. So that is how they have crafted this whole program beautifully. And I think first day, that is today, is focused on CA cervix. Then we have lectures on the I think ovarian cancer, endometrial cancer, and vulval cancer. So it's a fantastic, faculty that you have gathered for talking on various aspects of oncology in gynecology. And I must say that the all, especially because some over the years now we have lost touch on to the details of the oncological aspects. Then we have other specialties, fertility specialists, some people who are only practicing high risk pregnancy. So therefore I feel the young budding gynecologists who are going to be our audience, they will get a chance to understand the nitty-gritty of all these sub specialities, and they will be able to decide whether they would like to further follow their career in which specialty. So I think that is a job ICOG is doing very well. And I must once again congratulate all of you and the entire ICOG team for putting up a wonderful program. Thank you so much, both Saritas and Parag and the entire ICOG team. Thank you.
Thank you, madam. Thank you so much for those encouraging words. I now invite Dr. Parag Biniwale, who
Sarita,
is...
Dr. Sunita Tandurwadkar has
Yeah,
joined. So
yeah.
let's
Dr.
have
Sunita has joined.
Don't show my CV, please. Who is this? Please, no CV. No CV. Thank you so much. Thank you, dear. And once again, congratulations, Parag, Sarita, and the entire team. Sheila, I always appreciate you joining for Parag's All program. I notice you there. So that's a beautiful thing. Not only you know what is going on, but you can continue many good projects as it is because they have been curated with so much of a thinking. Suvarna, lovely to see you. My sweet secretary agrees with me most of the time.
Yes.
And
Sunita, I'm going to miss you next year, but you have to join on all the webinars and programs so that we don't miss you.
thank you so much. Thank you. This 3 days oncology, I think that is very, very important. Sometimes, yearly, since we are in a gynae endoscopy, I keep on entering onto the FIGO classification, or is there anything they added for C endometrium or any new markers? It's very important you keep on upgrading. So this 3 days extensive certificate course, I think more than even the postgraduate student, for the practitioners also it is very, very important. Sarita, you are one of the best committee chairperson doing a great onco work, and Parag has picked you up. That's a very important thing, Parag. I see you taking all my chairpersons in your respective field, so they feel nice, they feel getting involved, and especially they don't have webinars, so they love to have a touch of webinars. So thank you so much. And Sarita, please send me the flyer. No, I'll send immediately to all my students as well.
Sure, ma'am. I will just...
Thank you.
Yes.
Thank
Thank
you.
you. Thank you so much, madam, for joining and for your encouraging words. I now invite Dr. Parag Biniwale, who is the chairperson of the ICOG, and also he's held various positions in the past.
Thank
and
you,
is such a...
Sarita. Don't waste time in that, please. Thank you.
So,
Good evening. I bring greetings from ICOG, and it's indeed a pleasure to address the last certificate course of this year. And I'm really happy that the president of Foxy, Dr. Sunita, is here along with the Secretary General. Since this is the last certificate course of the year, next month we are not going to have one because the office will be really worked up with the fellowship preparations. I must appreciate the efforts put in by the three conveners of this program. And Sunita, incidentally, all of them have been chairpersons of the Gynae Oncology Committee, right from Dr. Harshad Parasnis, Dr. Bhagya Lakshmi Nayak, who are the past chairperson, and the current chairperson, Dr. Sarita Samsundar. And amongst three of them, they have divided the entire gynae oncology in 3 days, and they've picked up who's who of gynae oncology. And I'm sure it's going to be a great learning experience for all of us over next 3 days. I also appreciate the support given by three coordinators, Dr. Nishi, Dr. Usha Shri, and Dr. Likhita, who have taken up the responsibility of being the MOCs on all 3 days. My best wishes for the program and for all the delegates. Happy learning. Thank you very much.
Thank you so much, sir. Thank you so much for the encouragement and for the really the nice words for us. And actually Raki has been coordinating till now, but there was an emergency in her family, so unfortunately she could not join today. So at the last minute, Nishi has kindly agreed to coordinate. So welcome, Nishi. Chaudhary is the he's assistant professor in Obs and Gynae in the Department of Obs and Gynae at Vardhaman Mahavir Medical College and Safdarjung Hospital. So I request Nishi to take the proceedings further.
Thank you, ma'am, and good evening to all. And I must thank Foxy and ICOG for such an enlightening certificate course, which will be beneficial for all the young budding oncologists. Now, without wasting time, I will move on to the first session, which is on updating the primary and secondary prevention of CS cervix. For this, I would like to invite the chairpersons for the session. Our first chairperson, Dr. Kasturi Doninath. Ma'am is past president, KSOJA, director, Tatswara Hospital and ex-HUD Department of Obs and Gynae, KIMS Hubli. Dr. Asha Jain. Ma'am is director, SMSA Hospital, Raipur and medical director of Cancer Prevention and Relief Society. Welcome, ma'am. Dr. Sunita Malik. Ma'am is professor, senior consultant, VMMC, Safdarjung Hospital. Welcome, ma'am. Dr. Sarita Bhalerao, consultant obstetrician and gynecologist, Bhatia Safai, Reliance and Breach Candy Hospital, Mumbai, and also secretary of Indian ICOG. And I would further invite the speakers for the sessions are Dr. Helen Kemi, professor, Jawaharlal Nehru Institute of Medical Sciences, Imphal. Welcome, ma'am. Dr. Nilanchali, associate professor, All India Institute of Medical Sciences.
I think you invite the speakers one by one, no, Nishi? Let Dr. Helen begin.
Okay.
Then we can introduce the next speaker when that speaker is talking.
Sure.
Yeah,
Dr.
I think
Helen?
Dr. Helen, over to you.
Yes, ma'am. Thank you so much. Good evening. I'll just share my slide first and then I'll talk.
Actually, today's topics are, they're all on CS cervix, right from primary and primary prevention, then colposcopy, and then cancer. And the updates were also covering the latest FIGO update on the cancer cervix. So it's actually covering, it's a capsule on cancer cervix. So over to you, Helen.
Thank you so much, madam. When you asked me to speak on the emerging concepts, I was thinking, okay, so many. I mean, it's a very well-known fact because I think amongst every topic related to cervical cancer, HPV vaccination are really the rage right now. So I hope my lecture today will be useful. I'll straight away start with the topic with permission from our respected chairpersons. So this is a very well-known picture that is shown wherever we are talking about prevention of cervical cancer or treatment of cervical cancer. The global burden, even though the various shades of blue and red here is showing the incidence and mortality, but if we see our country, India, the shade seems to be in between the deeper shades and the lighter shades. So, but though this picture seems reassuring, the data are not. In India, we have a population of 469 million women aged 15 years and older who are at risk of developing cervical cancer. And of these, over 96,900 patients, new cases are discovered annually with reported deaths of over 60,000. This is not an encouraging figure, especially considering that the burden of HPV-related cancers in women is not confined to cervical cancer only, but extends to vulvar cancer, vaginal cancer, and anal cancers, which are all HPV-related cancers. So, but even though I'm talking about female only, we all know by now that cervical HPV related cancer is not only associated with cervix, vagina, and vulva, but it extends to male also who may suffer from penile cancer. And common to both gender, male and female, may have oropharyngeal cancers and anal cancers. Now, the concept of vaccines, when we speak, if we talk about screening, the age-old adage which applies to it is that make hay while the sun shines. But for HPV vaccine, it is the golden adage, that is, prevention is always better than cure. So the HPV vaccine concept is to prevent the new infections and in the process avoid the HPV related malignancies. Now in today's lecture, we will learn about the dose regimen, the existing dose regimen, and how there is a shift towards various shift in the regimen right now, and vaccines with broader range, therapeutic role, and gender neutral vaccine. So with this, I'd like to show this picture of this great personality. I think we all know him as Dr. Zurhausen, who first discovered the association of human papillomavirus with the occurrence of cervical cancer. He noted that this small DNA virus is actually causing cancer cervix, and association of the infection with squamous neoplasia of the anogenital region and oropharynx were also noted. With time, more than 300 genotypes were discovered with differing risk for malignancy. Now, human papillomavirus, there are 5 genera: alpha, beta, gamma, mu, and nu. Now, the alpha and betas are the most extensively studied. Beta human papillomavirus were known to infect cutaneous epithelium and are involved in occurrence of non-melanoma skin cancers. The alpha HPV infect both mucosal and genital epithelium and are the causes of the many anogenital cancers in humans and primates. The alpha HPVs are further grouped into what we know now as the low risk and high risk human papillomavirus. So the human papillomavirus 16 and 11 are the most notorious ones causing genital warts, and among the high risk we have this range of viruses causing cancers, and specifically for cervical cancer, 16 and 18 genotypes are known to cause more than 80% of the cancer cervix. Now, HPV infection is a very common infection. Almost 80% of the unvaccinated adults will have an HPV infection at one point in their lifetime. Now, the good thing is that most of these infections resolve spontaneously within 1 or 2 years. However, this exposure to infection does not provide any protection from subsequent infection or recurrent infection because the cervix does not have secondary lymphoid tissue, which is needed to produce the antibody and neutralize the virus before absorption. Now, part of this can be explained because of poor exposure to antigen presenting cells. I said because cervix is devoid of the lymphoid tissue, and no inflammation or attraction of immune cells, local immunosuppression, and no viremia. So these are the few notable causes as to why natural infection immunogenicity is very poor. Now, when this HPV infection becomes persistent, then the risk of developing precancerous and cancerous lesion increases. Now, our intervention, like I said earlier, prevention is better than cure. So we are trying to keep this picture of normal cervix permanent and break the conversion of normal cervix to normal cervix to prevent cervical infection to the cervix so that the cervix remains normal. So these two personalities are also worth mentioning because even though Zurhausen discovered the virus, these two personalities were instrumental. Dr. Ian Fraser and the late Dr. Jian Zhou, they discovered that even though it was accidental discovery, they discovered something called the L1, L2 virion structural proteins, which produce the viral-like particles. Now, before I'd just like to discuss more in details that HPV genomes, they have 8 open reading frames, which are categorized into early, late, and long control region. Now, of the E genes, which are mostly instrumental for viral replication and oncogenesis by altering the function of the tumor suppressor genes, the L gene actually are the structural proteins which are actually required for virion assembly. Now, of these, even though L2 protein is relatively conserved, it has been noted that the L1 genomes, they display differently amongst the various HPV types. The L1 protein is self-assembled into the viral-like particles, the VLPs, also known as VLPs, and this L1 protein, which has been expressed by the L1 genome, has been noted to be immunogenic, generating antibodies that can prevent future infection. So what is this HPV infection about? Like I said, the basis of the vaccine is the L1 protein. So these L1 proteins, the virus-like particles, they are made using a sophisticated recombinant technology where the L1 gene is expressed in recombinant yeast or baculovirus vectors. Now, the proteins expressed, they spontaneously assemble into what we now know as the virus-like particles, which is the which induces immune response. Now, morphologically and immunologically, these structures, they are similar to the native virus, but an important difference is that they lack DNA. So when we inject it to a person, they generate immune response, but they are non-infectious. And so the perfect vaccination, because I said earlier that the amount of antibody generated from natural infection is typically not enough to stop the reinfection. So perfect HPV vaccination should boost the immune system defense and protects against all high-risk HPV types, as well as those forms that are probably or maybe carcinogenic even. So there are 3 types of vaccines currently available in the market, various combinations. So we have the bivalent vaccine, which target HPV type 16 and 18. We have quadrivalent vaccine, which targets, aside from genotype 16 and 18, the low risk 6 and 11, which are notorious for causing genital warts. And the latest in the bandwagon, the 9-valent vaccine, which aside from 6, 11, 16, and 18 gives protection against 31, 33, 45, 52, and 58. Now, these are the various approved licensed vaccines that are available in the market, along with the year they were introduced. So we can see we have all heard about Gardasil, quadrivalent Gardasil 4, 9-valent Gardasil 9. But aside from that, there is Cervarix, the bivalent vaccine, which is against 16 and 18. There are 2 more bivalent vaccine in the market now, which has been licensed. That is the Sicolin and Walrin. Both are bivalent vaccine. Now, the efficacy has been studied and the efficacy has been noted to be similar in all cases. They are given intramuscularly. Volume per dose is also same, 0.5 ml for all. However, the adjuvant component differs a little bit for all these vaccines that are being licensed, and the vaccine antigens and the expression system, as we can see in this chart. Now, these are the various adjuvants, various vaccines under trial, which are being used for prophylactic basis only. Now, these are the dosage schedule that we already know of. So for WHO recommends 1 or 2 doses for age 9 to 14, 15 to 21 or 2 doses, and over 21, while it is similar for our Indian scenario. Reduced dosage schedule, this is something that we are awaiting from the Drug Controller General of India that reduce dose schedule single dose for girls and boys aged 9 to 20. If it is approved, then this will be followed in our country. So why the lower age? Why the 9 to 14 age? So these are the two main reasons. As you can see from both these studies, they found that the younger the age when they are vaccinated, the stronger the immunogenicity, and hence the protection level is higher when they are administered at a younger age. Now, so these are the global guidelines. They are the age range are almost similar. However, the target population sex seems to be differing a little bit. The reason being the WHO overall is focusing on the targeting the low middle income countries, low and middle income countries also. That is why their recommendations is stuck at female only. Now, gender neutral vaccination. Everyone is now talking about vaccinating not only female but male also, because we know that in female it has been a preventive effect against cervical cancer has been notable, and it avoids it protects against anogenital warts too. But in males also substantial proportion of oropharyngeal and penile cancer protection was seen. And not only that, vaccination of 9-valent or quadrivalent also protects against anogenital warts. So, and also it has been noted that the increasing incidence of oropharyngeal cancer has made the cost benefit of vaccinating males far greater than previously estimated and more in line with that for females. So is this a gender war? No. Now we know that the overall rate of transmission from male to female is much lower compared to transmission from female to male. So this seems to support the concept of why we should focus on females. However, many clinical trials have done and have shown that vaccinating males will not only help in decreasing the incidence and morbidity of cancer-related outcome, but also will help in giving herd immunity to the community. I'd like to talk a little bit about special populations like the pregnant or breastfeeding patient, those with pre-existing HPV disease, healthcare workers, and patients with HIV or immunocompromised conditions. We know there are certain conditions where the patients are immunocompromised. It has been seen that transplant recipients and patients with HIV with low CD4 count are at a high risk of HPV-related disease. Also, female with solid organ recipients with human papillomavirus are at 20 to 100-fold increased risk of cervical intraepithelial neoplasia. So the special vaccination in this population is highly recommended as per the age-related recommendation. Now, this I particularly wanted to mention because many of us are working in HPV-related diseases. So it even though the magnitude of the risk is unknown, it has been hypothesized that upper aerodigestive HPV infection may be transmitted through exposure to HPV in vapors generated during surgical excision or ablation of HPV-associated disease. Now, in a study of occupational exposure to human papillomavirus and vaccination for healthcare workers, Harrison et al., they argued that physicians and nurses and others who participate in the treatment of HPV-associated disease should consider vaccination. Now, for those with pre-existing HPV-associated disease, the question was whether it should be given or not. So this figure clearly explains. You see the prevalence of positive HPV DNA, all four serotypes, the high risk ones 16, 18, and the low risk 6 and 11. The chances that the person will be positive to infection from all these genotypes is very low compared to one infection with one genotype, 2 and 3 genotypes. So if this is the picture, then it is logical that we should give vaccination to those who have pre-existing HPV diseases.
Ma'am, sorry to interrupt
Now,
you.
for
Your
those with,
time is up.
Yeah, just give me 2 minutes, almost done.
Yes, ma'am.
So
Yeah.
many of us, we know that a majority of the reason why female visits our clinic is due to pregnancy. So we are at an ideal situation when we can actually talk about the vaccines and counsel. Having said that, during pregnancy, vaccination is not recommended. However, many big societies like FOXI, WHO, US CDC, and American organizations are also endorsing vaccination during lactation. Vaccine safety and efficacy has been proven in various big trials. This is why this particular slide shows why booster dose is not called for, because the one-time vaccination long-term effectiveness has been noted to be even high after even 14 years of vaccination. Also, no high-grade lesions or cervical or vulvar-vaginal cancer were noted after vaccination 14 years later on. Therapeutic role. Now, these are the areas that are being explored. Vaccines that we are using are primarily for prophylactic or prophylaxis only. However, it has been noted that if certain trials were developed, and they noted that the avenue for therapeutic consideration can also be given with HPV vaccine. So this was a particular interesting study done by article by Rui Wong et al., where 4 areas, aside from prophylaxis, the therapeutic nature of the vaccine is being explored. So the vaccines targeting E6 and E7 proteins, particularly in conjunction with immune checkpoint blockade, may pave the way for eradicating HPV infections and associated cancer as an attractive research area. Therapeutic vaccines in clinical trials have shown promising results in safety, HPV DNA clearance, tumor regression, and antigen-specific T-cell responses. Challenges, always financial challenge is always there. However, lack of awareness from public point of view, it's there, but even amongst healthcare workers, it is widely seen. So we need to address these problems in order to deal with the challenges faced for HPV vaccination. Now, this is the picture that has been shared because I wanted to show that India is still yet to be colored green, and we are really looking forward to, after having understood things in this class. And a good news in our country is that our policymakers are also starting to address this issue, and then definite HPV vaccination push has been done in budget 2024. Another good news is that we have indigenously developed vaccine which is given at a lower cost and as effective as the Western vaccine, and this can help maybe in reaching out to more population. With having said much about the prophylactic nature, which is very effective and safe, it should be mentioned that while giving vaccination, the patient should be made aware that screening has to be done at age-appropriate recommendations. This will help us achieve the 90-70-90 for cervical cancer elimination. Thank you for your kind. I'm sorry I exceeded 4 minutes. Thank you so much. Madam, will the question session be done later on, or like if there is any question, should I address it now, or we'll have the question later on?
Ma'am, we can have questions later on, and you can answer the questions if there are any in the chat box.
In the chat box, yes. Okay, thank you.
And we can now move on to the next lecture.
So can the chairpersons give their comments? Any of the chairpersons?
If the chairpersons want, they can give the comments at this point.
We can proceed now.
Okay, I will invite our next speaker. She will be speaking on the update of cervical cancer screening. Dr. Nilanjali. She is Associate Professor, Department of Obs and Gynae, All India Institute of Medical Sciences, New Delhi. Welcome, ma'am. She's Clinical Fellowship is Gynae Oncology, Calgary University, Canada. Over to you, Dr. Nilanjali.
Thank you so much. Is my slide visible?
Yes, ma'am.
Yeah, it's visible. It's visible.
All right. So we all know the best protection is early detection, and cervical cancer screening is one of the pillars. At the outset, I would like to thank ICOG for giving me to speak on this very interesting topic. So, respected chairpersons and dear friends, here I am to talk about updates on cervical cancer screening, whom to test and which test. Well, we all know that India leads the burden of cervical cancer, and therefore screening is utmost important. And we have an array of tests which are available. But the first and foremost important thing to note is that it is for asymptomatic women. And all abnormal symptoms must therefore be evaluated, and any suspicion lesion should be biopsied. So this is something which we all need to understand, that it is for asymptomatic women. Now, what are the screening modalities which are available? Well, I'll rather say that HPV testing is something which is now the first one to be mentioned, followed by, yes, of course, cytology, which has been there for a long time, conventional pap smears, as well as liquid-based cytology. Then co-testing has also been evaluated, and many are doing it. Visual methods, including VIA and VILI, are there. And then there are newer modalities too. So in the newer modalities, we know that mRNA detection, DNA methylation tests, oncoprotein tests, dual testings, they have all been evaluated, and some of them are there in the market as well. So cytology, well, it is the most commonly used screening test, and it has two methods. One is conventional, one is liquid-based. And here are the various sampling instruments which are used to prepare the cervical smear in the conventional method. And there is liquid-based cytology, in which the sample is collected by brush and sent in at the preservative media. The FDA-approved ones are SurePath, Thin Prep, Monoprep, in which the samples are set, and then there's a layer of cells which is prepared and it is evaluated. Well, if you want to compare these two methods, conventional versus LBC, conventional and LBC both have similar sensitivity and specificity. The only difference is that in LBC, the satisfactory rate is high, meaning thereby that you'll get lesser unsatisfactory results when you're doing LBC, because we are virtually capturing all the cells for evaluation. And overall, if we talk about cytology, then the advantage is that definitely it has very high specificity, but the disadvantage is that the sensitivity is lower when compared to other, specifically HPV test. So sensitivity is a little lower, and screening is all about sensitivity. So that is the drawback which cytology has over HPV test. And this is the system for reporting cytology. We all know the Bethesda system, NILM, ASCUS, LSIL, ETSIL, etc. So we move on to the next test which is available. It is there at many centers, HPV testing, and WHO recommends it as a primary screening test. It is also used as a test of cure. And the advantage nowadays, I would say, is also that self-sampling is also available, which can be a game changer in cervical cancer screening strategies. The advantage is that it is more objective, it is more accurate, sensitivity is higher. But the disadvantage is that, yes, it is less specific, it is lab-based, and availability and cost issues are definitely there. So that is one of the drawbacks of HPV. And then co-testing is also combining cytology and HPV can be done. Well, however, the data does not suggest that it is superior to HPV alone. So this is usually not recommended, and HPV testing per se individually suffices when we are talking about cervical cancer screening. And then the visual methods like VIA, visual inspection with acetic acid, in which we use 5% acetic acid, directly visualize the cervix with speculum, is definitely there. What makes VIA so attractive is that it is low cost, low tech, one step, and can be performed even by trained health workers, which are not even physicians. So that is one of the best advantages of VIA. However, the challenges are quality control, definitely, and inadequate training of personnel can lead to difficulties in interpreting the results. Well, but there are studies, many studies. One of them is this one, in which it said that VIA screening in presence of good screening and sustained quality assurance is an effective method to prevent cervical cancer. And this is why the WHO also says that VIA is still an option. And if we talk about VILI, which is visual inspection with Lugol's iodine, we use Lugol's iodine. We look for the mahogany brown and canary yellow colors. However, this test is not validated as a single method of screening. And then if we compare the accuracy, then cytology has the least sensitivity and HPV DNA has the maximum sensitivity. However, the specificity is more for cytology. And then there are newer modalities, E6, E7, oncoproteins, then P16, alterations of methylation patterns, alteration of host and viral genomes, where some of them are there in the market, but majority of them are not there. They are still under research evaluation. And then AI has come up in a big way to detect, precancers, and that is also paving the path for cervical cancer screening. So, well, we have an armamentarium of a test now. So the question is now that which ones we should be using and whom to screen. So I'll be talking about the WHO guidelines, the WHO 2021 guidelines. This I'll be speaking about the first, later on followed by what the other guidelines say. So WHO very clearly says that the first target should be that 30 to 49 years of women are screened. And if facilities are available, then 50 to 65 years should also be screened. And if we are screening women living with HIV, then the age group should be earlier, that is 25 years. They also say that primary HPV is the preferred screening methodology and cytology or VIA is an acceptable alternatives. They talk about screen and treat approach. They talk about screen triage and treat approach. Screen and treat, screen, and if positive, treat then and there. Screen triage and treat means triaging with another test and then going ahead with screening, with treatment. So WHO suggests that HPV is the primary method and partial genotyping, colposcopy, VIA, cytology, they are there to triage. And they have this huge list of screening recommendations. Some of them are strong recommendation, like we just spoke, when to do, which group is the age group is the prime target. So the prime target is this 30 to 49 years of age group, and 30 years it should start, whereas in HIV, as discussed, it should start at 25 years of age. And then how often to do it? Every 5 to 10 years in a normal individual with HPV DNA, and 3 to 5 years with HPV testing in HIV positive. However, if you are doing VIA or cytology, then it should be repeated every 3 years in both the groups. So this is what it says. But if we talk about our FOXY GCPR guidelines, they're almost similar, and they say that in good resource setting, the screening should start at 25 years of age, universally 30 years of age, and it should end at 65 years if there are 3 consecutive negative cytology results. And the interval is again 5 to 10 years with HPV and 3 years with cytology and VIA. And the screening should not be done if there is hysterectomy done with removal of cervix. Immunocompromised women, again, screening to be started at 25, and screening should, the difference should not exceed 3 years. So this is what the FOXY guidelines say. And they have also said that in good resource setting, HPV is preferred and cytology is acceptable. In low resource, VIA can be done if HPV is not there. And then I mentioned this ACOG. Well, we are not following it here, just to tell you that they have started earlier, and they say that we can even start screening at the age of 21. So 21 to 29, cytology is something which they recommend. After 30, they recommend HPV testing. We have 7 algorithms of WHO, and I can't go because of the paucity of time. I can't go each one of them one by one, just to show you that there are the algorithms of screen and treat approach, as well as screen triage and treat approach, in which they have used VIA test, they have used HPV DNA test for screen and treat approach, and they have used triaging by methods like cytology, colposcopy, and then HPV 16, 18. So it is just as simple to understand that either you screen with VIA or HPV and treat them, or you screen them with HPV and do a triaging with either VIA or HPV high-risk 16-18 genotyping, or a colposcopy or a cytology, and then you go ahead with the treatment. So overall, this is what they say. Now, if we move on to the screening in special population, now till now we know that whom to screen. So we have to screen 30 to 65 definitely, and 25 in immunocompromised population, including HIV. And how to screen? HPV available, screen with HPV. Not available, screen with VIA or cytology. So this is a very clear message which we all should learn here. Now talking about screen positives in special, or screening in rather special population. So in HIV population, WHO is also very clear. When to start screening? Well, the new evidence on WHO on women living with HIV says that screening should begin at the onset of sexual activity, and it should continue throughout a woman's life, even after the age of 65 or even after hysterectomy. So this is the difference which we should know. And primary HPV DNA is recommended as the main screening approach with a shorter interval. They now say that even 3 to 5 years it should be done. And if HPV test is positive, then triaging is must. We cannot do screen and treat in HPV women. PAPS test can be done if HPV is not available. And it is very important that we integrate cervical cancer screening in HIV care. So that is very important thing to note. Talking about women over 65 years of age, a lot of our women will never have been screened before 65. So cervical cancer screening for women over 65 only stops if they have normal results. The screening should be continued if necessary, particularly if there's a history of abnormal tests like HSIL. One can be screened way beyond 65 years, up to 20 years follow-up can be done. And in case of abnormal test result, the management should be as per the treatment guidelines. So if women over 65 have not been screened and no screening records are available, we have to continue screening after 65 years of age. Now, another question is screening in younger women less than 25. Well, as I mentioned that ASCCP says that we can start screening from 21. Well, it is not a very cost-effective method, and we will actually overtreat them. We will do unnecessary procedures. So most of the studies say that it is not usually recommended to screen less than 25 years of age. Now, screening in pregnancy, well, routine screening is often postponed. This is what we follow. But even if screening is to be done, then the timing should be early second trimester rather than first trimester or third trimesters. And these are the various guidelines about screening in pregnancy. And you can see that, most of the guidelines from ESGO, ACOG, SOGC, and Australia, New Zealand guidelines, they all say that screening can be performed even in pregnancy if she is due for screening. However, RCOG says that it should be deferred 3 months postpartum. So this is what it says about screening in pregnancy. Whereas colposcopy can be done if there is abnormal result and there is a suspicion of high-grade lesion, then only colposcopy should be done. Otherwise, for low-grade lesions, biopsy. Colposcopy can be done. For biopsy, should not be done if there is no evidence of high-grade lesion. Then screening consideration in renal transplant. So, well, it is again a very important situation. So American Society of Transplantation recommends PAP testing every 6 months for the first year after the transplant. So first year, 6 monthly screening should be done. However, it should be done yearly after. Well, this is there in the American Society of Transplant that screening should be done every year in a transplant recipient. This is something very, very important to be noted. And also they recommend that, again, transplant screening should be merged with transplant guidelines. And in transgender men, annual pap smear is again recommended for trans-masculine patients over 21 if the cervix is present. So another very, very important lesson to know that transgender men with cervix, annual pap smear is recommended, or annual screening is recommended. So my take-home message is screen, screen, and screen till the disease is eliminated, and even thereafter, continue to screen. Thank you so much.
Thank you. That was a wonderful talk. And I think both our speakers have really done justice to the subject. And on behalf of AICOG, I'd really like to thank you for participating as faculty in this program. I think, yeah. Dr. Sunita, would you like to? Yes, please.
I would like to say something. Nilanjali, you have done very well, and the topic is really good. We need to know the screening, the normal screening, then HIV positive, as well as immunocompromised, renal transplant. That's what it is. We have to be really extra careful. And my message to all the other people is, please don't do any HPV screening before 30 years. That's our this thing. So what's happening, it's being done, and then unnecessary triaging this and that, which is not required at all. So that sometimes I do get those HPV positive, madam, what to do next? So that's the important thing. And yes, she has done very well. And the questions will be in the chat box. Dr. Nilanjali, you please answer there. Thank you.
Thank you, ma'am.
Thank you so much, Dr. Nilanjali, for a wonderful lecture. Now we will move on to our next session, which will be the speaker for the lecture is Dr. Vijay Lakshmi Ramashankar. Ma'am is professor and head of the department, Cancer Biology, Molecular Diagnostic at Cancer Institute. Welcome, ma'am. And she will be speaking on HPV tests.
Good evening, everybody. Am I audible?
Yeah.
Yes, you are.
Sharing my screen, ma'am. Are you all able to see my screen?
Yes, we are.
Yeah. At the outset, I thank all the organizers for ICOG for giving me this wonderful opportunity to talk about HPV tests. I really like Nilanchali's last slide where she says screen, screen, screen. So I would like to, start with test, test, test. So we'll go over the different HPV tests that are available. Um, so what is HPV? We all know HPV stands for human papillomavirus. So it's basically a group of viruses which are diagnosed in more than 9, which is responsible for female cancers. So there are more than 100 subtypes of HPV, and it is mainly associated with the epithelial lesions and cancers which are predominantly on the cutaneous and the mucosal surfaces. So it's an epitheliotropic virus. So it is a very common sexually transmitted disease in the world, and that significantly impacts the social life of an individual. And HPV virus is classified into two categories: the low risk HPVs that can cause the anogenital and the cutaneous warts, and the high risk HPVs that can cause oropharyngeal cancers, anogenital cancers, including cervical, anal, vulvar, vaginal, and penile cancers. So they are associated with a variety of cancers. Now, why HPV testing is needed? Because it is a causal agent. So we are detecting a causal agent, and it has a high sensitivity for detecting a CIN2 plus lesion. And then when you do HPV testing in a screening program, one can have a longer screening intervals. So there are several studies which goes to show that women want longer screening intervals. They don't want to be frequently testing for HPV. So when you do HPV testing in a cervical cancer screening, the screening intervals are extended. It is adding to the cost effectivity of a program. HPV testing has got a superior sensitivity compared to traditional cytology. It is particularly good in detecting the high-grade cervical intraepithelial neoplasia and invasive cervical cancer. And the recent technical advances also show that HPV testing has significantly enhanced the detection and management of cervical cancer. So when you focus on improving the sensitivity and the specificity of HPV tests, they are important because they are crucial for effective screening and triage. Now, if you see the HPV detection methods, how we can go about it is one can look at the HPV genomes. We can detect the HPV genomes. One can look at the cell morphology, which has been changed because of an HPV detection. Or you can look at HPV antibodies. The body is producing certain proteins in response to an infection. So one could measure that, or one could straight away look at the HPV protein. So these are all the different methods in which you could detect. But many of us are very familiar with the HPV genome-based detection and the HPV cell morphology-based detection, where we have just looked at the presentation about pap smear, colposcopy, and VIA. So this is all methods which are pertaining to cell morphology. But in this, we will see in this presentation, we will look at what are all the tests which are important for detection of HPV genomes and HPV proteins. So if you look at the nucleic acid based testing, you can either have a DNA based testing or you could have an RNA based testing. So if you're doing an HPV DNA based testing, it will detect the presence of high risk HPV types, which is associated with cervical cancer. What is the specimen that you will be using? It will be a cervical swab collected, or a pap smear, or a swab of cervical cells in a particular medium, which will keep it preserved. The method will be a polymerase chain reaction, or it can be a hybrid capture method. Advantage of HPV DNA testing is high sensitivity and specificity for high risk types, and it is very commonly used in cervical cancer screening, especially for women over 30 years. And what do you do in HPV RNA testing? In HPV RNA testing, one detects the E6 and E7 nucleic acid amplification. By and large is isothermal here, and advantages indicates the active infection. So it is not just the presence of the DNA. The RNA test will let us know whether the infection is active, whether the transcripts are active, which can get translated into a protein, and therefore it gives us information about risk of progression, and it can also be used as a triage group, a tool for an abnormal pap. So what are the criteria for the HPV test? One important criteria is that it should be a validated test. You cannot use any test. Not all HPV tests are validated. So therefore, what do you mean when you say a validated HPV test? It maintains a minimum threshold for clinical sensitivity and specificity. That is, it should be able to identify maximum number of women who are at a risk of having or developing a CIN2 plus or worse lesions. So, and it should have non-inferior sensitivity and specificity to detect CIN2 plus or worse lesions, and it should be in comparison with a test like a gold standard, which has been validated in a well-designed randomized clinical trial. And there should also be a high intra and inter-laboratory reproducibility of that test. So these are certain criteria which should be kept in mind before we choose an HPV test. So let's look at what are all the different tests available. So this is the hybrid capture. Many of us are very familiar and would have used the hybrid capture system. It's a signal amplification system. So it's not a PCR based test. It is based on hybridization. So what happens is when you have your HPV DNA, the test has a RNA probe, which is, complementary to the HPV DNA. So the DNA RNA hybrids, which are captured on the microtiter wells, then are detected next with an antibody which is specific for this DNA RNA hybrids. So then there are two different probe cocktails are used, one for the low risk, one for the high risk. And this hybrid capture 2, that is HC2 HPV DNA test, was developed by the Dygene Corporation earlier, and it is marketed by the company QIAGEN. So this has actually replaced the original hybrid capture 1 tube. So the hybrid capture was a 1 tube format, but now what we are getting is a 96 well format. So once this DNA RNA hybrid is detected with the help of an antibody, this antibody will be coupled with a substrate, with an enzyme. For this enzyme, when you add a substrate, the enzyme substrate reaction will give rise to a luminescence. And this luminescence is measured in this technology. So these are all the different platforms which are available now for this based on the HC2 technology. You have the rapid capture system, which is for the high throughput HC2 assays. Then you have a middle system, which is a hybrid capture 2 modular system. And then you have the actual DML 3000. It is again a miniaturized version which can measure and analyze the HC2 assays. So the HC2 test has got a cutoff of 1 RLU. The RLU stands for the relative light units. So that luminescence that you measure will be measured in RLU. So any RLU greater than 1 shows that HPV is positive. If it is less than 1, then it is negative. But then when you have between, when it is 3 up to, it can more than 1 means it's positive. But if it is 3, then or it is 5, if it is 10, then you can still have an idea about the viral load. 3 may be a low viral load. If it is above 5, it is intermediate, and if it is above 10 means a very high viral load. So kind of you can get a quantitative idea about it, though it's not absolutely quantitative. The test has a sensitivity of about 0.2 to 1 picogram per ml, which is equivalent to 1,000 to 5,000 genome copies of HPV, and it does not distinguish between the HPV genotypes. So you will only know whether a HPV is positive or not. So if you have used a high risk probe, then you know high risk is positive. If it is a low risk, then a low risk positive. It will not be able to distinguish and tell you whether it is 16 or 18 or any other subtype. So, and it does not contain an internal control. That means it is not a molecular test, which means it cannot be satisfactorily used in a self-sampling, because the internal control will help us to decide whether the sampling has been done properly. So CARE HPV is based on the simplified HC2 technology. It has been developed to detect the 14 high-risk types. And this particular, it's like a point of care version of HC2. So it can be run in any setting. You don't need any special needs of humidity, temperature, electricity, water. It can be run by a health worker with minimal laboratory training. Cervical samples can be collected by a health worker or it can be collected on by this patient by themselves. So CARE HPV platform has been tested for self-testing as well. The results are very easily interpreted and it is available in approximately 3 hours. The limitations are that it is a low throughput assay which can do only about 24 to 90 specimens. So you have to wait till the 24 to 90 specimens are accumulated for you to run the test. And no genotype information can be obtained and there are manual pipetting steps. So therefore, one has to be very good in working with the system. Otherwise, it will lead to contamination and HPV is notorious for contamination-based issues. The sensitivity and specificity for CI and 2 plus is about 90% and 84.2%, while the standard HC2 parameters are 97.1 and 85.6. So that way, compared to HC2, CARE HPV falls short of sensitivity. So these are all the list of different tests which are available for the DNA and the RNA, and each of them has got its own pros and cons. So let's go with the Valgent. As I mentioned, any test that we are going to be taking, it has to be under the Valgent, it has to qualify under the Valgent framework. So Valgent stands for Validation of HPV Genotyping Assays. So currently when you do HPV genotyping, it falls into 3 categories. One is limited genotyping. That is, it will tell you whether it is 16, 18, or 45 positive. That is limited genotyping. If it can give you answers of identifying more than 5 genotypes, then it is called as extended genotyping. And full genotyping is individual identification of all the HPVs fall under the category of full genotyping. So the genotyping assays qualifying by criterion, that is the clinical accuracy of detecting a cervical precancer by aggregating all the type-specific information into high-risk HPV positive or negative. So the Valgent framework is important because it enables comparison and validation of these HPV genotyping assays using a relevant sample population. So in that relevant sample population, a gold standard comparator assay has been done and the results are available. With that result, when you compare the HPV genotyping assays results, and if they qualify, then it is getting qualified under the Valgent framework. So let us see what are all the assays which have got qualified under this Valgent framework and it is available. So Alinity M, this is by Abbott. It's a fully automated high-risk HPV test which was launched in 2019 and it targets the L1 region of HPV DNA of about 14 different high-risk types. So here you get the results in 5 distinct channels. It will tell you whether it is 16 positive, 18 positive, 45 positive. Then the other 2 channels are Group A and Group B. Group A means HPV 31, 33, 52 and 58. Group B means 35, 39, 51, 56, 59, 66 and 68. So 16 is the most virulent, followed by 18, 45, then Group A, then Group B. The clinical sensitivity and specificity of Alinity M to detect CI and 2 plus in patients in 30 years or older has been found to be 99%. And 100% specificity is there. And this particular test is performed by the Alinity M system. So if you see, it's a huge system. We got it installed in Cancer Institute very recently. So it's a huge, monstrous machine, and which is completely automated. And then the results are obtained with the help of a test software, which is based on comparing the cycle number values of specimen for each signal. And you have beta globin, which is used as an internal control. The next assay which is qualified under Valgent is COBAS. COBAS is a very famous assay which has been validated in a clinical trial, which is the Athena study, a largest clinical trial which has been done so far pertaining to HPV screening. And this test performed very well. And if you see, the specificity and sensitivity is about 90% and 93.5%. Specificity compared to HC2 is 70.5 versus 71.1%. So the main advantage of COBAS over HC2 is that it provides information about HPV 16 and 18. So COBAS is also available with the Cancer Institute.
Sorry to interrupt you. Your time is up, ma'am.
Yeah. I'm just quickly going through. So
Yes,
COBAS,
ma'am.
Yeah. So next is BD on clarity. This will target the E6 and E7. The assays which I told you so far was L1, but BD on clarity looks at the E6 and E7 region. Again, you can get subtype information, 16, 18, 45 and other subtypes. Then you have the gene expert. This is a point of care assay, which actually then and there, it's an on-site test. You can test and report then and there. So it is very helpful in screen and treat options. It's a multiplexed test again targeting the E6 and E7 oncogenes, so 14 types. And then you have the TrueNat, MolBio's TrueNat assay, which has got a very good sensitivity of 97.7% and specificity is 98.9. It's an India-made assay, which is post-COVID very much in use in our settings. And then you have the C-gene Anyplex. This is also there with us in the institute where we use this assay for individual genotyping. It's a real-time PCR-based assay by the C-gene company, which is a Korean company. So this also works very well. Then you have among the RNA, you have the RNA assay mentioned. We look at the E6 and E7 mRNA in an HPV RNA testing. So here we have the Aptima HPV, which is from the Hologic company, which measures the E6 and E7 mRNA of 14 high-risk types. So, and then you have the pre-tech proofer. This is also an mRNA-based assay, which is based on the isothermal RNA amplification. OncoSix cervical test. This is actually a lateral flow assay test which has been validated, and this is also kind of widely used these days, and this is a very new development. So there is this INDIC-AID HPV urine based test, which and along with ONT, they are this particular test is very recent, and it has been empowered by the Facify technology, which is going to be measuring the urine DNA, and then with the help of Oxford Nanopore you detect the 27 different types of HPV. Then you have the screen fire test by the Attila. This is this is a very recent publication, and this has been used in several IARC studies now. So these are all the different subtypes which can be detected, and this is an isothermal amplification based assay, very much like a point of care. And then you have a complete genotyping you can do by NGS. So you do a DNA extraction. So there's Uncoded and Chapter DX. They have their assay, which is based on an NGS based method to individually genotype. So we have done some studies to validate this uncoded assay. It validates very well with OBAS. So these are all the checklists that one should decide. This is my favorite slide. I would request all the people who are going to be doing HPV testing using HPV to take a photo of this, because this tells you, this checklist will help you to decide which test you should use for your screening program. Technology can save lives. We are in this era of technology. I thank you all for the attention.
Thank you, Vijay Lakshmi. You've done a wonderful job, and telling about all the tests in such a small time. It's a really exhaustive list which you have told. I just wanted to know this mRNA versus HPV DNA. Of course, for primary screening, we do HPV DNAs. So some people have started doing mRNA also, because that's
Yes.
costlier. So what do you recommend? What should
We have done, madam. So we have looked at HPV DNA versus HPV RNA, and then
Yeah.
we have compared it with the cytology. What we find is HPV RNA test definitely is more specific to pick up cytological abnormalities compared to HPV DNA. But the problem with HPV RNA is a stability. So when you're going to be using in a community-based program, we had several issues with the medium in which the cells were collected. Many of the times, the medium, the assays don't perform very well because RNA is very labile, it gets degraded, whereas the DNA is more stable. But if you are able to collect it on the thin prep, then it seems to work, madam. So if you are collecting your samples on thin prep and running this mRNA Aptima assay, seems to work better. So we have done a small, in about 500 samples, we have done this comparison, which we will be publishing shortly, ma'am.
That's good. And cost-wise, any difference? Of course,
Cost-wise, it is about, ma'am, this will cost you about 1,000 rupees, ma'am.
Yeah.
So it's kind of, we are leveraging the price like a DNA test, and it's a very good triage tool. We are trying to see how we can bring it to the community itself. So if we can work on the medium, which can keep the RNA stable, then it will be a game changer, ma'am.
Yeah. Thank you very much. So well, and thank you, Dr. Sarita and Dr. Sarita Bhalerab also for inviting us over. It was indeed very good session. And
thank you.
Thank you very much. Yeah.
I think Dr. Kasturi is she there, Dr. Kasturi? for any comment? No. I think we can go ahead then.
Dr. Asha Jain was also supposed to be there for this. She's not there. Okay. Now these are the instructions to all the delegates. I know all of you are asking for the PPTs, but the recording will be available on the ICOG website in due course. So do not keep asking for the PPTs. And attendance for all the 3 days is compulsory, and there will be an MCQ test at the end of this. So you'll need to get at least 15% marks on each day. So on all the 3 days. So only then you get a certificate from the ICOG, and they will give you your certificates within a month. Okay, so over to Nishida now.
Now, I thank all the chairpersons and speakers of the previous session for a wonderful and elaborative lectures. Now we move on to our next session, in which we'll deal with the basic of colposcopy and how it is very important for the secondary prevention of CA cervix. Now, the chairperson for this session is Dr. Usha Saria, consultant obstetrician, Breach Candy FI in Elizabeth Hospital, Mumbai, founder member, past chairman, and past president of ICOG. Welcome, ma'am. Our next chairperson, Professor Uma Singh, Senior Technical Director, University of Manitoba, and ex-HOD and Dean, KG Medical University, Lucknow. Welcome, ma'am. Dr. Shyam Pyari Jaiswal. Ma'am is Professor and Head at ERA's Lucknow Medical College and Hospital, Department of Ops and Gynae, and ex-Professor and Head KGMU, Lucknow, UP. Welcome, ma'am. Dr. Pramila Devi. Dr. Parimala Devi is a consultant obstetrician gynecologist and colposcopist with 38 years of experience. Presently, she is working at Parimal Healthcare and Colposcopy Center as well as Fortis Hospital, Bangalore. Welcome, ma'am. And our first speaker for the session, Dr. Leela Digumarti, ma'am, gynecologist, oncologist, St. Teresa Hospital and Avnis Hospital, Hyderabad, and immediate past president, Indian Society of Colposcopy and Cervical Pathology. Welcome, ma'am, and over to you for your session.
Yeah, thank you very much for your kind introduction. Yeah, let me share my screen. Yeah, is my screen visible?
Yes, ma'am.
Yes, ma'am.
Yeah, good evening, respected chairpersons, the organizing team, Dr. Sarita Shamsundar, Dr. Sarita Bellero, and the delegates who have joined Pan India for this wonderful program. At the outset, I thank the organizers for giving me this opportunity. So we have heard a lot about the importance of primary prevention in the form of vaccination and the secondary prevention in the form of screening, the availability of the various screening tests. So what is next if somebody is tested screen positive? So this is what I'm going to talk in the next 15 minutes about the role of colposcopy and how to set up the colposcopy clinic, and very briefly about the procedure of colposcopy and biopsy. So we all know that it's an important component of cervical screening program, especially when you have the triage option, that is screen, triage, and treat. So it actually helps us to evaluate the cervix, vagina, and vulva, helps us to diagnose pre-cancerous lesions and in situ cancers. It's not only for diagnosis, and especially the excisional treatments are done under the guidance of colposcopy. So it's very important to have a well-trained and informed providers. They're very, very critical for performing accurate and safe colposcopy. And that is the reason why the ICOG, FOXY, ISCCP, all the organizations are conducting various training programs. Colposcopy is actually a Greek word. Kalpos means fold or hollow. We usually focus the cervix through the vagina. Of course, we don't pass any instrument except the latest one of that smart scope, but otherwise we focus the cervix by keeping the colposcope outside the vagina, the scope is examined. So original colposcope, which was actually made, was a binocular microscope, and examination is done with magnified stereoscopic vision and good illumination. So we actually, if you use a real good binocular microscope, we get the 3D image of the cervix and everything we can see very, very clearly. The focal length of the most colposcopes is 25 to 30 centimeters. That is the distance between the lens through which we see to the cervix. The distance should be between 25 and 30 centimeters. Then you get a good picture. The magnification is from 6 times to 40 times, depending upon the instrument you use. Usually we try to see in a lower magnification and gradually increase the magnification. And especially if you want to focus a particular area, you can actually concentrate and magnify to get a more detailed information. So as I said earlier, it is very useful to study the surface epithelium, underlying connective tissue stroma, and vascular pattern. Hans Inselmann of Germany developed the first colposcope. All of us know about it. And slowly it has spread across the globe. So these are some of the pictures of the colposcopes, and this one is a binocular colposcope. It's a luxury to have a binocular colposcope, and most of us are using the digital colposcopes. So all the colposcopes have got a head, and especially in the binocular one, the head contains all the optics, and you need a light source. And of course, you need a camera, especially when you want to use the digital one, you have to focus it and see it. The digital one is a newer version where you are not using your eyes directly, but you focus it onto the cervix. On the screen, you will see the images. So these are again some of the pictures, the binocular one. And most of us are using the digital colposcopes, and lots of portable colposcopes are also available in the market. And the commonest one is EVA colposcope. And of course, several AI incorporated devices are also coming into the market, and which all need to be evaluated whether they are of, similar importance as far as the colposcopes are concerned, because most of us are very comfortable using either binocular or digital colposcopes. The newer ones have to be validated whether they are equivalent to the older versions. That is very, very important. So coming to the setup of a colposcopy clinic. So after knowing the equipment, we need to know how to set up a colposcopy clinic. So it's always good to have a dedicated clinic area and time, which may not be possible for everybody. Most of us at least use the gynae clinic. And if you have a decently sized gynae clinic, you can even put your colposcope there. But if you can devote some time, then you will definitely have a concentration at looking at the cervix and doing a proper examination rather than hurrying in between your busy gynae clinics. So trained team, as I said earlier, at least one trained colposcopist, the nurse who can help that colposcopist, and at least the other nurse who can do the documentation and other things. So at least a good team is very, very essential to run a proper colposcopy services. There are actually standards set for all these things. And according to your budget, you can buy a colposcope, be a binocular, be a digital one. Then, of course, in the clinic, you need to have an examination couch, which is comfortable both to the patient as well as to the operator, that is the colposcopist. And instruments, all of you know about the instruments. We need to have various sizes of Cusco's specula, gloves. Then we need to have the biopsy forceps. We need to have the sponge holding forceps, artery forceps, so many instruments what we usually use. You need to maintain a proper tray, which I'm going to show in the next slide. Then, of course, chemicals. We are all familiar with the important chemicals, that is acetic acid, Lugol's iodine, Monsell's paste. So you need to buy glacial acetic acid, distilled water, and one can prepare their own Lugol's iodine preparation by buying potassium iodide and iodine crystals. Then it's always better to have a treatment facility, at least the ablation in a smaller setups, if you don't have that training to do an excisional procedure, because most of the times it is most of the lesions can be treated by ablation. Then one should not forget to follow the disinfection protocol and waste disposal. These are some of the pictures of the colposcopy clinic. So here we have a table which is adjustable, so that the patient can be brought to the edge, and then on the side the thing we can keep all the instruments and we can do it. So here, because this is a digital colposcope, you need to have a monitor. and it is connected to a system, and we can always enter the details, everything into the system, because most of the digital colposcopes have got a software, and it will run through the software to enter the details, the documentation and everything. Then after that, you can save a lot of information, the images, and then you will be giving finally the report to the woman who comes to you for colposcopy. And this information can be used for any further analysis in future. So this is the tray. This is actually the left one is from the IARC manual, but you can make your own tray according to the needs what you have. So as I have shown here, you have the Cusco speculum, you have the swab sticks for application of various solutions. Then you have a sponge holder, you have a small artery forceps, and you have a tissueless biopsy forceps. So if you take a biopsy, that the tissue can be taken out from the tissueless forceps and can be put it into the formalin solution. So you have acetic acid, and one has to prepare this acetic acid every day, the 5%. So if you are in a large camp setup, you take 95 ml of distilled water and add 5 ml of glacial acetic acid to make it 5%. And each day you need to use it, and if anything is left behind, you have to throw it. And of course, you can make small quantities according to your requirement, basing up, keeping the standard of 5% acetic acid. So if you are using only for 1 or 2 women, usually I take 19 ml of distilled water and 1 ml of glacial acetic acid. And the Lugol's iodine, I prepare myself in our lab, and we keep it for a month in a brown color bottle that has to be stored in a brown color bottle. Then Monsell's paste, yes, you can have your Monsell's paste. And sometimes for a smaller biopsies, even a small gauge pack also can be of a great help. Then this is the equipment for ablation. You all know about the cryo. Now of late, we are using thermal ablators because especially the Lega thermal ablator is quite easy to handle, and it's battery operated. And we can take it even into the community and do it without any difficulty. So both for screen and treat, especially where ablation is indicated. Now majority are preferring thermal ablators over cryotherapy. And if you have the facility to do the excisional procedures, you can keep, you can have an outpatient excisional machine. And most of us are still, at least when you don't have such a facility, you can use your cautery machine to do this procedure. There is a portable excision device is also available, which probably can be used for taking smaller biopsies in the clinic setup. So after knowing the setup, when we should consider for colposcopy, you have already heard about the various screening tests and what happens if somebody is a screen positive, what is to be done next. So to triage after a positive screening test, VIA positive, cytology positive, high risk HPV positive. Dr. Neelanjali nicely has described the various algorithms. So wherever there is an indication, the lady has to be referred for a colposcopy. Apart from a screen positive test, any suspicious looking cervix, persistent vaginal discharge, postcoital or intermenstrual bleeding, one needs a colposcopic examination. And treatment of CIN, especially Lee Parledge, are usually done under colposcopic guidance. Then after treating the CN, if they need a follow-up, sometimes we need to do a follow-up colposcopy also. So what is exactly the principle of colposcopy? So in colposcopic images, what we usually do is we focus the light onto the cervix. So the amount of the light that passes through the tissue depends upon the architecture of the epithelium and the underlying stroma. Usually normal epithelium of the cervix acts as a filter, so through which both the incident and reflected light pass. So when the cells are normal, most of the light passes through the epithelium and then it reflects back. Epithelium is colorless and stroma is red due to blood vessels. In a normal woman in a reproductive age, in a multi-layered ectocervical epithelium, we usually don't see blood vessels, but if it becomes thin, like in a postmenopausal woman, the epithelium becomes thin and the underlying blood vessels in the stroma are seen, which is a normal appearance in when we do the colposcopic examination. So how much light passes through the cells and how much light is reflected, everything depends upon the nature, the architecture of the cells, the epithelium, what we are actually looking at with light. So if you see this picture, you will understand if epithelium is normal, the nuclei are normal, the cytoplasm, everything is normal. Even if you put acetic acid, most of the light passes through the cells and reflects back. So you won't see any S2 white changes. On the other hand, if there is any abnormality in the epithelium, after putting the acetic acid, only little light passes through it and most of it is reflected back. That's where you see those aceto-white changes. So that is the principle of using acetic acid and seeing the aceto-white changes. So after understanding the principle, when you are doing a colposcopic examination, you have to do in a stepwise method. So first of all, you have to inform the woman why she is called for colposcopy, and you have to take a consent. Then if you are using a digital, nowadays everybody is using the digital technology. So either you can use a hard copy writing on a paper, or it is better to enter into a software if you are using a digital colposcopy or whatever it is. Even binocular ones also have got a software, so you can enter all the details. Then do a stepwise examination. So focus the cervix, examine it properly. Then after that, you visualize, once you have completely visualized, clean the mucus, apply a green filter, then apply acetic acid, wait for a minute, and then have a relook at the cervix. Then after that, you apply iodine. So the stepwise examination has to be done. And then of course, everything has to be documented. This is from the IFCPC. Usually this is the standard way of doing a colposcopy. The documentation part is going to be covered by the next speaker. So then once you have done everything, you have to explain to the woman what you have done and then what is your plan of action. So all these things, and wherever indicated, you will be doing a biopsy. So just
Ma'am,
once,
sorry to interrupt you. Your time is up,
yeah,
ma'am.
this is the last but
Yes,
one
ma'am.
slide.
Okay, ma'am.
So when it comes to taking a biopsies, usually when you do a colposcopy, you find an abnormal areas. It's better to take a biopsy to know what exactly is happening there, what is the grade of the CIN and other things. So it should be obtained from the area of the lesion which has got the maximum suspicious thing, which is close to the squamocolumnar junction. Of course, you need to take multiple biopsies. Sometimes you may see a lower grade lesion in the upper lip and maybe smaller, higher grade in the lower lip, but you need to take multiple biopsies. And if you are taking in different areas with different grades, it's better to put in separate bottles and send for histopathological examination. Biopsies usually differ in pregnancy. Punch biopsy is the one which we usually commonly done. And rarely we need to do endocervical curettage, especially if you have a type 2 or type 3 transformation zone, or the lesion is extending inside, or you don't see any lesion outside, but the cytology or the HPV test is positive, then there is a role for endocervical curettage. Or if you have a cytological abnormalities in the glandular abnormalities, then only you have to do endocervical curettage. A loop biopsy sometimes we do, and the cone biopsy. These are the pictures of some of the biopsy forceps. What if you have a visible lesion? Most of us use a bigger biopsy forceps to take the big chunk of the tissue for examination. So this is, I'll skip it because these are the videos. So finally, my take home message is to undergo a structured colposcopy training, to have a dedicated colposcopy clinic, to understand the equipment, to keep everything ready before the procedure, to do stepwise examination, to participate in colposcopy MDT meetings to enhance your knowledge, and to audit your colposcopy practice regularly. Thank you very much for the opportunity given to me. Thank you.
Thank you, ma'am. And I would request Dr. Usha Saria, ma'am, to give her expert comments for this lecture.
Everyone must be knowing Dr. Usha Saraya. She's a pioneer in colposcopy in India and has established colposcopy, so many years ago. So it's a privilege for us to have Madam Usha Saraya here.
Thank you. Can you hear me?
Yes, ma'am.
I'm sure whether you can hear me.
Yes, we can.
Okay. So thank you very much. To be 182 district centers where we want to make great and very cover of frame so data and this need has to be fixed by ours.
Can you speak? Can you go closer to the computer, ma'am?
Yeah, cannot get.
It is breaking actually.
Is it not loud?
It's breaking actually. Voice is breaking.
My voice. Just 1 minute. My
Yeah.
Sami,
Okay.
is it better? Can you hear me?
Yes, better. Yes, better, ma'am. Yes.
Yes,
I can't get the vision now. It doesn't matter. Can you hear me?
Yes, we can hear you.
So, I just wanted to tell you that there are 782 districts in our country, and every district will have hope to have a detection center where all these facilities will be needed. And all the students who are registered today will realize that there is scope for them to do this work. And certainly, our students will fulfill our dream of making the initiative of Cervical Cancer Mukt Bharat successful. So I congratulate ICOG for conducting these courses, and I congratulate all the speakers for giving very elaborate and nice lectures to our students so that they will be our future colposcopists for India. Thank you.
Thank you, ma'am.
Thank you so much.
And I would also request our speakers to please answer the questions in the chat box.
Okay.
And now I will be moving on the next lecture, which will be taken by Dr. Archana Mishra. She is professor at the Department of Ops and Gynae, VMMC and Safdarjung Hospital. Welcome, ma'am.
Thank you, Nishi. Should I share my screen?
Yes,
Yes,
please.
ma'am.
Yes, please share.
At the outset, I would like to thank Dr. Sarita Shamsundar and all the ICOG team for making me a part of it. I'm trying to. It's not going full screen. From where it has to be done?
मैम ऊपर लिखा है एनिमेशन के बाजू में स्लाइड शो होम इंसर्ट डिजाइन.
Okay, from the beginning. Okay, fine.
Yeah.
So my topic is reporting colposcopic finding on the tissue basis. So my job has been made very easy by Dr. Leela, that she has explained about the light and all the things. So awareness and ability to identify colposcopic features of a normal cervix provide the basis for differentiating between the abnormal and normal colposcopic finding. You will be able to find abnormal only when you know what is normal. So I'm not going into this. So how does a normal cervix look like? A normal cervix look like this. So just see my cursor, there is something which is light pink. There is something which is red. And there is a zone which is demarcated by this blue line where this pink and red meet. If you apply acetic acid, then you will be able to see some milky white areas here. And there will be a pink thing. And this red thing has gone into whitish. But after some time, this color will fade and it will be looking, if we apply Lugol's iodine, it will look like this. So what is it? This is columnar epithelium and this is squamous epithelium and this is squamocolumnar junction. So if you go in detail and if you have a very nice colposcope, you can see this columnar epithelium, it looks like grape-like, and even you can see some papillary projections like this. So ectropion with grape-like epithelium in the ectocervix and caudal position of squamocolumnar junction due to effect of hormones, OCPs and infection. We all know this. So
this squamous columnar junction has moved caudal, and then after some time it will start healing and there will be metaplasia and it will go towards cephalad. And there will be a milky white area because the cells are not mature enough. Their nucleus is large. So if you apply acetic acid, then these large nucleus will take white color. So this is the metaplasia. So this is the normal one where you can see the capillaries, and this is a grape-like structure of the villi. Then there is metaplasia. There will be increase in the cell number and there will be a cleft in between. And after some time, this cleft will be filled with the cells and it will take a light pink color. So tip of the villi is becoming white. So if you see this thing, it will also look like a mosaic, but it is a reverse mosaic because the tip of the villi are pink and some of the villi have coalesced to form thin squamous white layer. And peninsula or tongue of the metaspastic epithelium can be seen, and some crypts opening are apparent in this. Here you can see this whitish sort of milky white sort of the color, and here you can see what is it? It is reverse mosaic. So this grape-like configuration of columnar epithelium disappear and the space between the villi is fused to glassy pinkish white finger and mildly pale and tongue-like membrane pointing towards a. So this is always a finger-like thing and it is always pointing towards the internal os, and numerous crypt opening can be seen. On acetic acid application, faint aceto-white area with an indistinct irregular geographical margin and faint reddish iodine uptake can be seen. This is totally normal. It is just a metaplastic epithelium. So normal arborizing cervical vessel, these are normal. These vessels divide and their caliber progressively decreases in size. But this is also normal. This is a network of capillaries. So these are also normal. These are staghorn capillaries. This is also normal. They will be seen in the cervicitis where you can see this vessel is enlarged, but this is tapering in the end. And these vessels can be having a regular branching arborizing pattern. So these are all normal. What is this? This is chronic cervicitis. It may look very fearsome to you, but it is totally normal. So these are the vessels which I was talking about. These are enlarged vessels, but they are tapering and they are having a normal arborizing vessels, this thing. And if you take a iodine color, so it will take a faintly iodine. So this is not canary yellow. It is taking a faint color of the iodine. This is candidiasis, a white color which patch you can see. It is present even before you have applied acetic acid. So if you clean it, it will look like this. And if you
Ma'am, your
apply
slide is not visible.
my slides are not visible, but
Yes, ma'am.
this is showing your screen is sharing.
We can see that.
Click on the slides, ma'am.
We can, I think
Reshare it.
we can see it.
Is it visible or not?
I can see,
Yeah,
Dr.
it's visible.
It's
Okay.
visible.
So this is a favorite picture of examiners. This is trichomoniasis.
No,
Some
now
of us, it is
we
not
can't see.
visible.
It is not visible.
Okay, I will stop sharing and I will start
Yeah.
sharing again. Fine.
That would be better.
Join again. Yeah, now it is.
Now it is
Visible
visible.
now?
It
Okay.
is visible now.
Yeah. So
Now
this
it's
is the columnar epithelium which has been in the in a very acidic media for a very long time, and this columnar epithelium has shown overgrowth and it is shown a polyp sort of thing. So this tip is permanently exposed to vaginal environment and got metaplasia. So this is also normal. So this is a Nabothian cyst. The glands have become, this gland has been this gland opening has been covered by epithelium and the mucus inside has formed a cyst. Sometimes even it is so big that it can be seen on the ultrasound also. The glands can become this enlarged. And on this, you can see this vasculature like this, which is not abnormal. It is totally normal. So this is a rounded bump-like thing. This is cervix in pregnancy. This is deciduosis of pregnancy, hypertrophied villi of columnar epithelium, copious mucus, apparently S2 white patch due to very prominent crypt opening and tips of the villi. and it is not canary yellow. It is totally taking color. This is mustard. This is mahogany green, mahogany brown, and this is you can see this is decidosis of the pregnancy. When you take a postmenopausal woman, this is something looks like this. No osteoid area. The squamulocolumnar junction is not visible. A few prominent vessels is seen near the external os, and fine capillaries seen all around through the thin intraepithelial epithelium. And patchy iodine uptake in both anterior and posterior lip of the cervix. So condyloma of the cervix, it takes white color. It is something velvety white, and it is if you apply acetic acid, sometimes you may get confused, but this is nothing else. It is just a condyloma of the cervix. Congenital transformation zone, it is a tongue-like projection of columnar epithelium. It may extend up to the vagina. So this is a very large columnar epithelium which is exposed to the for HPV infection. So you should be able to diagnose the congenital transformation zone. Post-treatment changes, that is post-radiation changes. So cervix is gone inside, hang up high, and you can see abnormal. These are totally normal vessels. The epithelium is too thin. Colposcopy is often inadequate due to vaginal.
Excuse me, I would request the coordinator to make sure the slides are not visible to many more people still. So maybe one more attempt of stop sharing and sharing, because there is no point, especially these slides, if are not visible, it does not serve the purpose.
Actually,
Nishi may,
should I stop share and share again?
Yeah.
Nishi may take the call, please, and Dr. Sarita. But because many people are writing.
Is it visible now to everyone?
No, many people are writing. Just see in the chat box, many people are writing.
Yeah,
that
actually,
the-
there was one participant who had started sharing her screen. That's why I think it was not visible to few of them. I have just stopped the sharing of that participant.
Okay, it's visible now. Okay. Right.
Should I
Okay, there was
continue?
some Dr. Anita. Yes. Okay.
Yeah, ma'am, you can continue.
Okay,
Yes.
thank you, ma'am. So these are the post-LEDS changes. So you can see radial lines of scarring. Multiple crypt opening is seen in the anterior lip, and a small transparent white area is seen at the 1 o'clock position in this. And pale streaks of post-lip fibrosis can be seen. So what is abnormal? Now we will see the abnormal thing. So these are the normal vessels, and there is a large number of cells which has grown inside. So now you are able to see only the tip of the villi. So this is mosaic. The blood vessels, rather than confined to the lamina propria, extend to the surface of the epithelium, and a distinctive punctuation can be seen. So this is what we write as punctuation of the vessels, and colposcopically red dots can be seen and perforating the aceto-white epithelium. It is very important. If something like mosaic is present in the aceto-white area, then it is very important to document. So this is mosaic. Sometimes these vessels form a basket-like patterns on the surface. Instead of forming a mosaic, they form a tile-like pattern, which can be seen like this. So this is also a abnormal finding, and it should be documented as abnormal. Coarse mosaic and punctuation. Can you see this? All this mosaic, they have different calibers. There's no regularity in this mosaic. So this is intercapillary distance is spacing is uneven. The distance between the capillary loops increases as the amount of the cell proliferation increases. As such, the greater is the grade of the CIN, the greater is the distance between the capillary loop. Coarse punctuation seen in HISL, and it is characterized by the large irregularly sized dot that may appear above the surface epithelium. So atypical vessels. Now this is a very important slide. You can see these are the spaghetti-like appearance. These are atypical vessels of invasive, and they have comma-shaped appearance. Atypical vessels of squamous epithelium, it may be having a corkscrew-like epithelium. You can see there is no difference in the caliber. This vessel is thick and the caliber is not decreasing in the end, and there is no arborization of the vessel. So this is abnormal. So there may be noodle-like or hairpin-like pattern also. Atypical vessels of the invasive cancer, and they increases in size instead of decreasing in size. So these are all minor grade lesion. You can see this is before application of the acetic acid. When you have applied acetic acid, so there is a milky white area in here. And this squamocolumnar junction is fully visible, and multiple thin acetowhite area can be seen at 12 o'clock and 6 o'clock, 9 o'clock position. The margins are irregular, and after acetic acid, partially iodine uptake can be seen. These are all major grade area. This is before application of the acetic acid on the green filter. And this after application, you can see it is total oyster white and opaque, and the lesion is extending into the endocervical canal. And if you see on the green filter, it looks like this. And the crypt openings are also cuffed. The dense aceto-white area with a regular margin can be seen at the 5 o'clock and 3 o'clock position. And lesion extend into the canal as ridges. And the aceto-white after this, it is taking canary yellow color. This is also a major grade lesion. You can see before application of the acetic acid and after application of the acetic acid, a large aceto-white area with the regular margin extending to almost all the quadrant. The lesion is at 7 o'clock is denser than the rest of the. So there is a lesion within the lesion. And there is a small aceto-white area at the 9 o'clock position. And the aceto-white, when it is stained with the Lugol's iodine, you can see it is canary yellow color. You can see here. So at 7 o'clock, definitely it is a higher grade lesion. So then this you can see there is a aceto-white area, but there are absence of the vessels. So it is a higher grade lesion. And this is a very important thing. Here is a rag sign. The desmosomes which has been able to pick the, I'm just completing it. So the desmosome which has keeping the epithelium to the the subcutaneous thing to the subepithelium, it is not there. So it is just peeling off. So there is a rag sign. This is frank invasive cancer, which all should be able. There is torn epithelium or in the eroded area as seen as the rag sign, and coarse mosaic can also be seen. You can see there are tiles, there is mosaic and multiple erosion, dense aceto-white area and iodine negative area. So thank you for a patient hearing, and I'm sorry that some of the participants were not able to see some slides.
So thank you very much, Dr. Archana. I think you have done a great job of trying to show normal and abnormal findings of found during colposcopy. However, I think all the people must carry the message. It's not easy to learn, abnormal findings very quickly. This has been a great presentation, but we must make effort to undergo a detailed training of colposcopy to really start learning the colposcopy. But the images must be kept in kind of, reference type so you can understand what are those. Thank you, Dr. Archana, for beautiful presentation.
Thank you, ma'am.
Thank you, ma'am, for the excellent colposcopic pictures. And now we will move on to our next topic, which is principle and methods of managing CIN. And speaker for our session is Dr. Bindya Gupta. Ma'am is Professor, Department of Ops and Gynae, UCMS and GTB Hospital. Welcome, ma'am. Over to you now.
Thank you so much. At the outs, let me just share my, I'll just see whether I'm able to share. Is my screen visible?
Yes, ma'am. You can put it on slideshow.
I'll just do that. So at the outset, I would like to thank Dr. Sarita and the entire team of ICOG for giving me this opportunity. And it's an excellent course and with lots of information in the next 3 days. So excellent, very well drafted course, ma'am. So today, a very important topic, principles and management of CI, principles of management of CI, and also the methods. So we've gone through two beautiful lectures with Dr. Leela and Dr. Archana showing what is colposcopy and what are the findings. So when we, just a moment. So when we take a colposcopic guided biopsy, what we get in the histopathology is a report of CIN or cervical intraepithelial neoplasia or maybe even invasive carcinoma. So we all know that the cervical cancer, which is caused by infection of HPV. So initially it's an HPV infection which results in some cholestatic changes. It gradually progresses to CIN1, CIN2, CIN3, and finally invasive carcinoma. And a lot of lesions, they regress back and a few progress. So that is the natural cycle of the cervical precancer to cancer. And with the last classification, this staging of CIN1, 2, 3 has been changed to a binary classification of LCIL and HCIL on histopathology, in which LCIL basically is CIN1, while HCIL corresponds to CIN2 and CIN3. So CIN2, which is P16 positive, is mainly HCIL. When it is P16 negative, we normally call it as LCIL. So with this background, our objectives in this lecture will be to understand the management principles of CIN and see the various treatment options. So treatment of CIN, we know, should be effective. That is, not only we have to treat the lesion, but basically we have to treat the transformation zone and reduce the risk of cancer to nearly zero. It should be safe with reducing the risk of complication to an absolute minimum. And whether the TZ is being excised or destroyed, a depth of 7 millimeter treatment is considered to be optimal, be it ablation or be it excision. And effective pre-treatment counseling is very important. So let us understand the various stages of CIN. So coming to LCIL or CIN1, we can see that the majority of CIN1 regress and only less than 1% they progress to invasive cancer. So who can progress? A CIN1 which is preceded by an HCIL cytology or a persistent infection with HPV 16 and 18, or if the molecular markers are positive. So CIN1, because of the high rate of regression, it merits an expectant management. So you can observe that if the patient is compliant and regression without treatment in 2 to 4 years' time is guaranteed. So at least for first 2 years, we can have a watchful expectancy on CIN1 by timely cytology and by colposcopy. But when do we treat? So if there is persistence of CIN1 at 24 months, especially when CIN1 is preceded by a high-grade cytology, or the grade increases, that it becomes CIN2 or 3, or the lesion size increases, in those cases, we should go for treatment for CIN1. Sometimes when we are in low resource settings and we can ensure that the patient is the non-compliant, she's non-come for follow-up, in those cases, better that you treat the patient and then send her. Or sometimes in ASCCP 2019 says, for cytology showing HCIL, but a biopsy showing histological LCIL CIN1 or less, an immediate diagnostic excisional procedure is also acceptable in these situations. Now coming to CIN2 or 3, that is HCIL, as we can see, 5% of CIN2 progresses to invasive cancer and 14% of CIN3 progresses to invasive cancer. So here we have to be very cautious. So for that, the guidelines are very standard and acceptable. That is that HCIL, especially for CIN3, treatment is recommended and observation is unacceptable. For CIN2, that is histological HCIL, treatment is recommended. And whenever we have a situation, excisional treatment is preferred over ablation, but ablation is also acceptable, especially in those settings where the excisional treatment or the expertise is not available. But when we consider ablation, the criteria should be met, which we'll be detailing in the subsequent slides. Topical agents, application of imicumod, therapeutic vaccines, etc. are only in research settings. It is not a recommendation at all. And hysterectomy, very important, hysterectomy as a primary therapy for CIN2 or 3 is unacceptable. Now, as I said, that for HCIL CIN2, treatment is preferred, but yes, observation can be done. In which situations? If the patient has concerns about future fertility, in those situations, observation with colposcopy and HPV-based testing at 6-month intervals for up to 2 years can be done. And the ideal cases in those situations will be those who are non-16-18 HPV positive or who are P16 negative and have small lesions and are immunocompetent individuals. Now, coming to glandular lesions, we know that glandular lesions, they extend into the endocervical canal, they escape lesions, they can have some concomitant squamous disease also. In those situations, whenever we are suspecting CGN or we are suspecting AIS, excisional treatment is mandatory. So this is an algorithm which is given by by the ASCCP 2019. So as you can see here, diagnostic excisional procedure should be done in AIS to rule out invasive cancer. If margins are negative, hysterectomy is preferred, because we can have we can have some lesions inside the endocervical which we have not taken out. Or sometimes, if suppose margins are positive, especially if the radial margin or the endocervical margin is positive, we should go for hysterectomy. And conservative management is only acceptable if future fertility is desired, but with a very, very strict follow-up. So this is about the adenocarcinoma in situ. There's another term called expedited treatment, which is defined by ACCP 2019, that even if you don't have a preceding colposcopic biopsy, and it is, but the immediate risk of CIN3 is more than 60%. In those cases, we can take up the patient directly for an excisional procedure or for ablation, especially in those situations when we have an HPV positive, genotype positive for HPV 16. So therefore, expedited treatment without the preceding colposcopic biopsy is also recommended in certain situations. That is a see and treat approach we need to do in the colposcopy clinics. Now, we're coming to special populations. In adolescents which are less than 25 years, significant regression is seen, and therefore primary management, you should not treat, because that will result in overtreatment. We should keep them on a strict follow-up with cytology and colposcopy. Don't do HPV in adolescents, because that can lead to a false positive diagnosis. Coming to pregnancy, Nilanjali had told about a lot of pregnancy guidelines. So every trimester, colposcopy with or without biopsy when required, and excision only if invasion is suspected. Otherwise, wait for the postpartum, because the lesion may regress. Immunocompromised HIV positive, a very strict, again, approach should be taken. Whenever suspicious, take a biopsy, and we should always follow a screen, triage, and treat approach in these patients and continue the heart. Now, coming to the next aspect of my presentation, that is treatment methods for CIN. Now, as I said, the treatment should be effective, safe, and the depth of treatment should be 87 millimeters. So modalities can be ablative or excisional procedures. The ablative modalities are cryotherapy, thermal ablation, laser ablation, or rarely earlier they used to do even electrocoagulation or radical diathermy. Excisional procedures include LETs, cold knife conization or laser conization, or needle excision of transformation zone, or straight wire excision of the transformation zone. Out of these ablative procedure, more commonly we do the cryotherapy and thermal ablation, and for excisional procedure, most commonly done is the LETs. So how do we select the treatment modality? So it depends on the severity of the lesion, whether it is persistent CIN1, 2, or 3. What is the type of transformation zone? What is the size of lesions? Number of quadrants involved in the cervix? What is the age of the patient? Parity, fertility, aspirations? What is the clinical skill and the experience of the operator? Previous treatment, if she's undergone ablation, go for excision now. What is the availability of equipment? What is the likelihood of default from follow-up? And what are the results of triage test, whether there is HPV 16-18 status and the biomarker status. Now, coming to ablative methods, as I said, cryotherapy and thermal ablation are the most common ones. So there's specific eligibility criteria that whom you can ablate. So as Dr. Archana had shown in her colposcopy lectures about the transformation zone, so anything with the type 1 transformation zone, that the lesion is fully visualized on the cervix, or a shallow type 2 TZ, where the entire probe can be covered by where the entire lesion can be covered by the probe, especially in cryotherapy. Those are the ones which are eligible for ablation. There should be no evidence of invasive cancer, no evidence of glandular disease. There should be no history of previous treatment on cervix. Women should not be pregnant, and there should be no evidence of PID. For thermal ablation, the lesion size is not a restriction, because we can do multiple applications. So this is the lesion. So can you see here? This is eligible for ablation. You can see the entire lesion can be covered by the probe. But if this lesion, such a big lesion extending into the fornices, extending into the endocervix, this is not eligible for ablation. As I said, the two important are cryotherapy and thermal. So cryotherapy basically relies on the principle of intracellular water destruction by double freeze thaw freeze technique. So here we are basically the intracellular death is caused by the freezing, by lower temperatures. So areas slough halves and separates in about 10 days. So this is how the cryotherapy crater looks like. Then thermal ablation, this is the instrument, handheld and the benchtop type of thermal ablator. Here we are treating the thermal destruction by a boiling point up to 100 degree. And this is how you apply the probe, and this is how the lesion is undergoes a thermal ablation. So advantages of thermal ablation are high cure rates, safe, simple and OPD procedure, no anesthesia, short learning curve and cost effective, and no major complication. But the disadvantages basically are the bulky equipment, especially when we go for cryotherapy, and less effective for larger lesions, and concerns about the depth of destruction. And obviously tissue is not available for histopathology. We don't know about the margin status. And with cryotherapy especially, there is profuse watery discharge. Now, coming up to about excisional methods, these are the excisional methods, out of which LETS is the most commonly done. Now, coming to types of excision, depending on the type of transformation zone, we have type 1 excision, that the lesion is entirely visible on the cervix. So this is the type 1 excision. If we have the type 2 type of transformation zone, the lesion is going into the endocervix, but you can see with the application of the forceps or with this thing, so that is type 2 excision. And when the upper limit of the lesion is not visualized, that is called as the type 3 excision. So look at this chart very carefully. So type 1 excision can be done for any grade of squamous CIN, especially for CIN3. And the techniques used are LETS or the LEAP, that is they're interchangeable terms, or we can also do laser excision. These type of lesions, type 1 lesions, are also eligible for thermal ablation or by cryotherapy. Coming to type 2, in the type 2, basically, we can do for any grade of squamous CIN, but this has to be type 2 type of transformation zone where the lesion can be just visible in the endocervix. Again, the modalities are LETS or the LEAP. We have sweats, we have laser excision, or we can even take a small cone. Type 3 excision, the lesion is extending into the endocervical canal and we cannot see the upper limit. There's glandular disease in the woman, which is more than 36 years, suspected microinvasion. In these situations, it's better to go for cold knife conization or sweats or a needle cone excision. LETS or LEAP, in this, if you're doing a LETS or LEAP, in this, we have to take a top hat excision also. So therefore, it's better to do for type 3 lesions, especially glandular disease, it's better to go for cone or needle excision of the transformation zone. Few images. This is how the LEAP station looks like. You have the loops and you have the insulated speculum. And this is how the loop is being taken. The lesion is being dissected from below upwards. Then this is how the needle excision of the transformation zone is being done. The needle is taken all around the cervix and the specimen is removed. Now, what about CGIN? If suppose you have a glandular disease, we have to do a cylindrical type 3 excision. And that should be done only in the hands of experienced operator. We have to have a one-piece specimen. So if the fertility is desired, they limit the excision up to 12 to 15 millimeters. Because what we are worried about here is the skip lesions in the endocervical canal. We should not miss any disease. And if the fertility is not desired, the length of the cone should be at least 20 to 25 millimeters of the endocervical canal epithelium and should also include the transformation zone. Now, last but not the least, the criteria for single visit approach and strategies. What is see and treat approach? So in the colposcopy clinic, if the patient has come with an abnormal cytology report and we are seeing it's a high grade lesion, as I told about expedited treatment, then and there only we can see the lesion and you can treat it either by excision or by ablation, and then you can do the post-hoc analysis of the biopsy report or the excision specimen. What about screen and treat? In a screen and treat setup is basically done in the public health programs. You're doing VIA and you detect an abnormal lesion, and there if the criteria for ablation is fulfilled, you immediately take a thermal ablator and you can the patient treat. You can just treat it there. Now, what was the basis of these see and treat and screen and treat approaches? It prevents the loss to follow up. It ensures compliance, and there is the patient can follow up, can be treated well. What about hysterectomy? As I said, it is too radical. Please don't do hysterectomy for CIN. However, in situations like we discussed earlier also, if you have an AIS, in those situations, you can do a hysterectomy if you have positive margins, or if they suspect microinvasion, or if the patient has concomitant gynecological problems like fibroids, prolapse, or endometriosis. In those treatment, the cure rates are almost the same, just 2 minutes, almost finishing. And if we compare with the LETS, recent meta-analysis showed that cold knife conization and laser conization had better results, while the thermal ablation is almost similar to success rates as compared to the LETS. Cryotherapy is a little bit inferior, but yes, whatever modality you have, please treat the patient rather than not treat, rather than just following up. Now, what about follow-up after treatment? WHO recommends that retest at 12 months with HPV DNA testing. And if the woman, and once it is negative, then you can go for regular screening interval. And if women living with HIV, 12 months reports have to be there. And then only the patient can go for the routine screening. So to summarize, for SIN1, again, I'll repeat, observation, only persistent CIN1 up to 2 years should be treated. For CIN2, treatment is desirable, but observation is also acceptable in those situations which we had deliberated earlier. For CIN3 treatment, excision is preferred, and for CGN and AIS, excision is the mainstay of our treatment. Ablation is a reasonable alternative, but the criteria should be fulfilled. Excisional method should be done under colposcopic guidance, and the indications are very, very clear. We have the various type of excisions depending on the type of transformation zone. We have to choose a modality and follow up with HPV testing, preferably with HPV and cytology if available after 1 year. So thank you very much. So together we can achieve this goal. Thank you very much.
Thank you, ma'am. I would request Dr. Shyam Jaswar to have a valuable comments. Ma'am, please unmute. Dr. Shyam, you are muted.
Admin office, can you please unmute Dr. Yeah, yes, now I think she can. Dr. Jaiswal? Okay, we can take Dr. Parimala's comments and then Dr. Jaiswal
Thank
for
you,
the
Dr.
next talk.
Sarita and Dr. Parag, for this beautiful opportunity to be with all these stalwarts of talk. Every talk is really refreshing, and we are understanding the things more and more for the better. And it was very nice to meet Madam, my mentor, Dr. Usha Saraya. Namaste. And I think the talk of Bindya is so clear that the first motto is to see that we were not allowing the lady to go for the invasive lesions. We have to diagnose it in a very early stage of CAN before it becomes more progressive. And of course, the observation in the second CAN2 and excisional methods in CAN3, and also keeping the hysterectomy in CAN3 plus if it is progressing. These are the important things like we have really understood. And also the special category like the fertility where they want to preserve, and the adolescent girls not doing unnecessarily HPV test, and of course convincing them for the HPV vaccination is very important. And also we can, pregnant ladies are a separate category, and the whole like Bindya could put everything so well in these 15 minutes of whatever given. Thank you. Really, it was very clear, and I really, of course, all the speakers and Bindya's topic now for CN1 management. Thank you so much.
Thank you for unmuting me. Thank you for unmuting me. I'm not able to. That is because I tried to join from another. Dr. Vindya, your talk was wonderful, excellent. And you have explained everything according to in which condition what we should do. I'm sorry because it was not working, so I joined from another instrument also. So I'm closing. So क्या है एक भी नहीं काम करता है तो ज्यादा ही काम कर रहा है. So talk was definitely Dr. Sarithya, really sorry, but really very informative. I'm really thankful you have asked me to join here. And Vidya, you have explained in the CIN1, CIN2, CIN3 how we should treat. Thank you. Thank you so much. And really, I feel, as Dr. Uma said, and Dr. Saraya also said, this message should go to the periphery also, because still we have lots of this problem when the patient comes in advanced stage to us. If colposcopy and CNT should be started at every place, even small center, definitely it would be helpful to pick up the cases early. That is. Thank you so
Yes,
much
see,
for
Patel,
being for us.
one half a minute. Calpohystroscope, anything like something is going on? Because you're all in medical college, anything
Yeah,
to
yeah.
try to
In our medical college, we have colposcopy. We are doing it also. But
There have been studies with using this, but we are not doing it on a regular basis. There have been theses in our department.
Thank you, ma'am.
Now, moving on to our next topic. Can we have the CV, please? The topic will be how to manage and case-based CIN approach. And speaker for the lecture is Dr. Sarita Shamsundar. Ma'am is Professor, Unit Head, Gynae Oncology Unit, VMMC and Safdarjung Hospital. Ma'am is Chairperson, Foxy Gynecological Oncology Committee. Welcome, ma'am.
Thank you so much, Nishi, and thank you again, ICOG, for this invitation. So, screening and, selecting, we doing screening is easy, but then treating after screening, managing after seeing is a challenge, and it's a bottleneck which is a problem everywhere. So, how to select the right approach, and which is the approach, and how to select it? So Bindi has gone over all this. So CIN1 mostly regresses, CIN2 maybe around less than half of them regress, and CIN3 only one third of them regress. Most of them persist or they go in progress to invasive cancer. But the fact is, even CIN1, there is a 1% chance of progression to invasive cancer. That is why follow-up is so very essential. The time to progression is up between 10 to 20 years. However, we have these aggressive HPV types, which is especially 16 and 18, where the progression can be faster. It can be as short as 1.5 to 2 years also. So I'm just going to show some case scenarios, and we try to see, what the lesion is and how best to manage. So this was a 34-year-old lady, her para 2, found to be, it was VI positive, and then she had colposcopy, and you find this is the first one is after normal saline, and this picture is after acetic acid. And this also is after acetic acid and the green filter, and this is after Lugol's iodine. So you see these aceto-white areas in all the quadrants of the cervix. So although it does not look like a major grade lesion, but there is a minor grade lesion up on in all the 4 quadrants of the cervix, and it's also iodine negative. In the on biopsy, it showed CIN1. Now, looking at the type of transformation zone, if you see it is a type 1 transformation zone because we can see the squamocolumnar junction in its entirety. And if the options are the biopsy or if showed CIN1, either we observe or we treat. So we observe the women who are willing to come for follow-up, but those if they are not compliant and cannot come for follow-up, then we offer treatment. And we see a lot of women who actually opt for treatment. We do counsel them about this in our clinics, and many of them opt for treatment. So then if she opts for treatment, what do we do next? So this this since it's a lesion which is completely outside, and it's a type 1 transformation zone, and it is eligible for ablation. And with thermal ablation, although if it's a big lesion, but we can do multiple applications, and this can be easily treated by thermal ablation, which can be done in the clinic in less than a minute. Now coming to the second case, which is lady is a 34-year-old lady who's high risk HPV positive. Now if you see on the right side, you see a lesion which is a dense acetovite lesion, and you can see it has well-defined margins, and on iodine, it appears it's completely iodine negative. There are no areas of patchy iodine, so it is iodine negative. So here, so the colposcopy finding sites an adequate colposcopy. It's a transformation zone type 2 because here you cannot see on the anterior lip you can see the squamocolumnar junction here, but on the posterior lip you cannot see the squamocolumnar junction. So that means it's a type 2 transformation zone, and even on manipulation we could not see it. So and you have a lesion which is going which is a dense acetobite lesion. It's going into the endocervix, and we cannot see the upper limit of the lesion. So in this case, and on biopsy it showed CIN2. So in this case, since this is a lesion which cannot be completely treated by ablation, we need to go for excision, and the excision for this method, we can go for LETs because it is something which can be easily covered in a loop. In one loop excision, we can take it out. So even without a biopsy, a prior biopsy, you see a lesion like this, it can still be we can go for excisional method straight away. So it's an excisional biopsy as well as treatment. So that is called see and treat. Now another lady, Mrs. A. Now this is a common problem that we are facing nowadays because there are so many ladies who are delaying their pregnancies, and we have a 33-year-old coming from primary infertility, and on investigations, she was found to be high-risk HPV positive. So then this is a picture with normal saline. This is a picture with the green filter, and here you see this post-acetic acid. Are you able to appreciate the acetovite lesions? You can see these acetovite lesions, in fact, in all the quadrants of the cervix. Here, all the quadrants of the cervix. Nisha, are you able to visualize?
Yes, Dr. Sarita, very
Okay,
clearly see.
good. Okay, so here also you can see these acetovite lesions here. And also this is post-glucose iodine, so there is patchy iodine uptake in all these lesions. So here the colposcopy is adequate. That means we are able to see the cervix completely. It's a transformation zone type 1 because we could see the entire squamocolumnar junction very clearly. So it's entirely, we can see the squamocolumnar junction. So you see these acetovite areas in all the 4 quadrants of the cervix. So as far as size is concerned, the score will be 2. Now coming to the acetoviteness, since it is the acetoviteness, it is acetouptake, it is distinct, and the margins are sharp and irregular, and it is occupying all the 4 quadrants, and it's patchy low. So the sweet score is 6. Now what to do next? So we took a biopsy, and the biopsy, a 4 quadrant biopsy. So the biopsy showed CIN1 in some areas, and some areas it showed CIN2. Now what to do next? So should we observe her or should we treat her? Is a dilemma. So, and now, but she's also worried. If we want to observe her, she's also worried about progression. So what do we do next? So what Bindya was also telling about is what is the progression rate. So we see a lot of women in this age, they do regress. Now if in this age, young women, they do regress. So the regression rate can be as high as 71%, or it can be between 39 to 71%. So now what to do? She's now planning a pregnancy, but she's also worried about the effect of the treatment on fertility, of any treatment. So if we treat, then she's worried about her fertility issues. So what can we do? So we do something called as P16 immunohistochemistry. That is, on the tissue we apply the immunohistochemistry stains, that is P16. Now presence of P16. Now P16 is there in all the CI. Any biopsy you will find P16, but it is the amount of P16 staining which is significant. So if you have just scattered staining like this, that is a wild type, that is not significant. Here, if it is just scattered here, diffuse positivity, this is CIN1, whereas here, if you see, it is in the 2/3 of the epithelium. So this is CIN2, whereas this brown staining, that is the P16 staining, if it is occupying the entire thickness, that is called block positivity, and that is significant, that indicates CIN3. So in this case, there was full thickness of positivity, and since there were multiple lesions, so then the only option was to go for ablation by thermal ablation. So she was offered thermal ablation, and that was done. So does the thermal ablation affect fertility? That is another issue. So there are many studies and there's a lot of evidence showing that it does not affect fertility. It's only the excisional methods, and that too, if the depth of excision is more than 10 millimeters, that can increase the risk of preterm labor. Now coming to the next case, Mrs. B, a 34-year-old lady with who actually presented with AUB, and on pap smear she is found to have LSIL. So this is the cervix without anything, with normal saline, and this is the green filter, and this is after applying acetic acid. If you can appreciate the faint aceto-white areas on the posterior lip and also on the anterior lip, and also the iodine, this patchy iodine uptake. Now here we can see the squamocolumnar junction on the anterior lip but not on the posterior lip, and even on manipulation we could not see the squamocolumnar junction on the posterior lip. So therefore the colposcopy is adequate. So it's a TZ type 2 and the aceto-white areas, and the SWEDE score was 4. Now what to do on the biopsy? The biopsy actually showed CIN2, but so what to do next? So we have a TZ2. So we go back to the picture. If you see now, it is now, should we go for ablation or should we go for excision? Now again, if you look at this lesion here on the posterior lip, there is a lesion, but we cannot see the upper limit of this lesion. So therefore, then we decided to go for excision. Now, since the whole thing can be taken out in bilets, so that's was planned for this patient. The next patient is a 42-year-old lady who's HPV positive. Again, high risk HPV positive, and colposcopy you find these dense aceto-white areas. Now this picture has been this courtesy IARC, the digital atlas of colposcopy. So you see these dense aceto-white areas, and also on iodine, this is iodine negative, and you can see the canary yellow. So here colposcopy is adequate. That means you're able to see the cervix completely. It's a TZ transformation zone type 1, and it's a high grade lesion on both the lips. Now what do we do now? So either we go for punch biopsy first, so go for biopsy followed by planning the management, or go for excisional method in the first instance itself. Now in this is a lesion which is a high grade lesion, so a lesion like this we can go for excisional method in the first instance itself. So that is the excision. It will be an excisional biopsy as well as it will be the treatment. So this is what is called as see and treat. So you see in colposcopy and you plan the treatment straight away, rather than taking a biopsy and coming in and waiting for the biopsy report and then planning the management. So that actually reduces the loss to follow. Now this lady, a 38-year-old para 3, again she was found to have HSIL on PAP, and that's why the colposcopy was done. And here so it was a TZ type 1, and you can see it's a high grade lesion on both the lips of the cervix. You can see on the posterior lip, and also it's ID negative. Now what do we do for this? Can we go for no, we go for biopsy and treatment, or go for see and treat? Now now the biopsy showed CIN3, so can we go for LETs? Now if for LETs we need to have a lesion which can come, the whole lesion you should be able to remove in one piece, in one sitting or multiple passes. But this was a lesion which was almost going into the fornices, so this was not the case for LETs. So then a cold knife conization was done, and it was found to be CIN3, and all the margins were negative. Again, a lesion like this, you can see it's a dense aceto-white lesion, and again going almost onto the fornices. This case is not suitable for LETs because it's a big lesion, and we will not be able to take out the lesion in one piece, and even with multiple passes, it's because it's a lesion going into the fornices. So here cold knife conization should be done, or conization should be done. Now another lady of 50, yeah. So I'll just go rapidly. A 48-year-old para 2 with AUB, PAPs showed abnormal glandular cells. Now, one important thing is also sample the endometrium to rule out any endometrial malignancy. So this was the colposcopy picture. You see dense aceto-white areas, and this is a TZ type 3 because you can't see the squamocolumnar junction in its entirety. You see these abnormal vessels, and you see ID negative areas on all the four quadrants. So it is ID distinctly yellow. So this the sweets. It was a major grade lesion, TZ type 3, and because there were abnormal glandular cells, so it's important to see the endocervix completely. So that is only possible with a cone. So conization was done in view of this, and on conization, we got positive margins because it was a big lesion, and therefore it was actually the margins of the cone. It was the endocervical margin which is positive. Therefore, a hysterectomy was done. The last case, a 33-year-old lady, again, she's para-1, screened at a camp, found to be screen positive, and pap smear found to be HSIL, and she was HPV16 also positive. And here you find these dense acetovite areas, and there is peeling also. Now on biopsy, this found they reported it as CIN3, but this looks like microinvasion. You see this peeling of the epithelium. This is very typical of invasive carcinoma. So then we went for a conization, and that confirmed that it was a malignancy. It was a squamous cell cancer. So therefore, that is why it's important. Now, it was very difficult to convince the patient that she needed a two-step procedure instead of she kept insisting on a hysterectomy, and instead of going for a conization first. So it's if you do a hysterectomy, a simple hysterectomy in this case, it would have been incomplete treatment, and we would have landed up with a recurrence. So see, because CIN3 may be associated with invasive carcinoma, and simple hysterectomy is an incomplete treatment. So it's only indicated when an excisional procedure is not possible, and you find the margins to be positive, or the lesion extending into the vaginal fornix, or you find glandular lesions on the cervix. So this is an outline of the treatment of CIN. So CIN1, first of all, assess this type of CIN and the grade and the type of TZ. So CIN1, either you can observe if compliant, or and persistent, you can go for treat, or non-compliant, go for ablation. CIN2 and 3 definitely need to be treated depending on the type of transformation zone. If it's a TZ1 or 2, you can go for ablation, whereas CIN3 and TZ3 definitely goes for excision. So the treatment of CIN is simple. It's nothing complicated, not like robotic or laparoscopic surgery. It's not rocket science. Single visit approaches are available, they're practical, acceptable. They minimize the loss to follow-up. It's basically two things you need to see: type of TZ and what is the grade of lesion. That determines the type of treatment. And all methods are easy to learn. There are a lot of learning resources on the WHO IARC website, on the ISCCP website, on the IFCPC website also. So let's all work for 90, 70, 90 and make our country free of cervical cancer. So November is the cervical cancer elimination month. And this is, I thank ICOG for giving us an opportunity to do this in this month of the cervical cancer elimination month. And this was 17th of November. All of us went to the India Gate, where it was lit in the teal color. And not only that, there was the temple in the Orissa, which was also lit up the teal green. So thank you once again. So let us all work for the eliminating cervical cancer from our country. Thank you once again.
A big round of applause. That's all I can say.
Thank you.
Excellent, excellent. There is no,
Very
although
interesting
all
case.
talks are very excellent and very informative.
And these cases were very
Yeah.
interesting, the last
Very
case.
interesting. And cases are very interesting, really. And sometimes it's so difficult to make decision, especially the person is infertile or having one child and want to conserve. So in fertility conservative surgery is a very difficult too. I remember I had one girl who came as a case of infertility, just 25 years old lady, and biopsy says it was malignancy. It's so difficult to counsel ki let's we do the conization, we do the tracheostomy only. But ultimately she went into the radical surgery. And I can't forget that girl, such a young girl. So sometimes it's very difficult to take the decision. Thank you so much.
Yes,
Excellent
thank you.
cases, very good. And thank you
Thank you.
for inviting us and including us. Thank you so much.
Thank you, Ben. Thank you. Thank you to all chairpersons and the speakers.
Thank you,
So,
ma'am,
Nishi,
for
over
the
to you.
yes, ma'am. Thank you for the wonderful session. Now we will move on to our last session, which is about cancer cervix. And for the session, I would like to invite the chairpersons. Can we have the CVs, please? Dr. Nisha Singh. Ma'am is professor and head of the Department of Gynae Oncology, King George Medical University, Lucknow. Welcome, ma'am.
Thank you.
Dr. Ashok Kumar Paddy, Associate Professor in Gynae Oncology at AHPG Institute of Cancer, Cuttack, Odisha. Welcome, sir. Dr. Sunil Kumar Giri, ex-professor, PG Department Gynae Oncology and former director, HA Postgraduate Institute of Cancer, Cuttack. Welcome, sir. And the speaker for the first session is Dr. Jyoti Meena. Ma'am is professor, Department of Ops and Gynae, All India Institute of Medical Sciences, New Delhi. Welcome, ma'am, and over to you. And also, I would request the speakers to please answer the questions in the chat box. Meanwhile,
Thank you, Nishi. And good evening, all the seniors. Today I will, I'm just sharing my slide. So today I will be talking about the cancer of cervix uteri. This is the 2025 update. So I think my slides are visible, Nisha ma'am?
Yeah.
Okay. We all are aware that cervical cancer is the second most common cause cancer among the women, and there are around 6,62,000 new cases every year, and around 3,48,000 deaths occurring because of this. And it is the fourth most common cancer in the women after breast, lung, and colorectal among all the cancers. And so it is very important to know about this cancer and what are the prevention strategies and the screening strategies. So this I am not going into detail about the anatomical consideration. We all know that almost all cases of cervical carcinoma, they originate from ecto and endocervical mucosa in the transformation zone, which lies between the original and the new columnar junction Then the persistent infection with HPV is now the recognized causes, the necessary cause for this disease. And more than 80% of women, they acquire this infection once in their lifetime. Most of them, around 80 to 90%, they clear this infection within 2 years. But those who have a persistent infection, they are at risk of developing cervical cancer. And 16-18, they accounts for 78% of cervical cancer cases. So the prevention strategies and early detection strategies are there. So primary prevention, we all know, is by HPV vaccination, and secondary prevention. And WHO global strategy also states 90-70-90 goals with a vision of cervical cancer elimination as a public health problem by 2030, with a threshold limit of 4 per 1 lakh women years. So primary prevention with HPV vaccination, we all know that overall the global cross-sectional HPV prevalence in healthy women more than 30 years is around 11.7, with our highest regional prevalence in around sub-Saharan Africa. So the HPV prevalence peaks at around 25% of the women in less than 25 years. And this indicates that this infection is to be primarily targeted before a sexual debut. So that is the basis of the HPV vaccination target population being girls 9 to 14 years. So we all know that there are several HPV vaccines which are available for the use for in girls and boys aged more than 9 years for prevention of pre-malignant lesions and the cancers. Now the WHO 2022 also recommends that there should be 1 to 2 doses in girls between 9 to 14 and 15 to 20. And in more than 20, 2 doses are to be given.
And currently 80 countries are implementing two-dose schedule, and more than 60 countries have implemented a single-dose regime in their national program. So at the population level, there is evidence that there is effectiveness of HPV vaccination in terms of reduced prevalence of HPV types, anogenital warts, and high-grade cervical abnormalities, and among the women who are receiving the vaccine types, and there is evidence of cross protection also among the non-vaccine types as well. For secondary prevention, WHO guidelines have clearly states three screening strategies in form of HPV testing, which is the preferred modality, and most of the countries are now going forward with the HPV testing as the primary screening test. Others are cytologic, which can be conventional or LBC or the VIA. The emphasis is on the single visit approach because it minimizes the loss of to follow up and also improves the coverage, compliance, and cost effectiveness. So most screening guidelines, they recommend screening every 5 years. WHO cervical cancer elimination strategy has recommended 2 lifetime HPV based screens at 35 and 45 years using a validated HPV test. And in low resource setting, even 1 lifetime HPV screening can provide significant benefit. And those who are vaccinated, if HPV screening is further added, then this can help in eliminating cervical cancer a decade earlier. So whenever there is countries introducing cervical cancer screening program, the guidelines should clearly indicate the target age group, screening test, the method to reach the target women, management of screen positive, the treatment methods that are to be treated for pre-invasive lesions, and the criteria for the type of the treatment. So now there are studies from Bangladesh and India which have observed that following the right approach to organize several components and meticulous attention to quality is crucial to the success for any screening program and not merely the choice of the good test. So now we all know that invasive cervical cancer, it spreads by direct extension to parametrium, vagina, uterus, and adjacent organs. And through lymphatic channel, it reaches the regional lymph nodes, and through hematogenous, it reaches distant. So in 2018, FIGO revised the staging to allow the option of clinical, radiological, and pathological findings to assign the stage. We are all aware about this FIGO staging. What is the main changes in this FIGO 2018 changes? The main changes were that the horizontal dimension of microinvasive lesion is no longer considered. The tumor size has been more stratified. That is, in B1, the tumor size is less than equal to 2 centimeter. In 1B2, it is more than 2 to less than equal to 4 centimeter. And in 1B3, it is more than 4 centimeter. The lymph node positivity correlates with poor oncologic outcome and assigns the case to 3C if there's pelvic nodes. 3C1, it is called 3C1. 3C2 when it is paraiotic nodes, and if there is micrometastasis, then it is also included in stage 3C. So this revised FIGO staging closely aligns with the latest TNM staging, and the stage is allocated after all imaging and pathology reports are available, so it is not altered at a later date if there is any recurrence. So it is essential that all cancers must be confirmed by microscopic examination, and WHO has given a histologic classification for these tumors, also cervical tumors, which is squamous epithelial tumors, glandular, other epithelial tumors, mixed epithelial and mesenchymal tumors, germ cell tumors, and the neuroendocrine neoplasm. The important is that they have divided now them into HPV associated and HPV independent. So what is the difference between HPV associated and dependent cancers? The HPV associated one, as we know that there will be HPV oncoproteins will be detected, while in HPV independent, there will be a genetic mutation, which is P53 or KRAS mutation. On IHC, the P16 will be strongly positive in HPV associated, while weak or focal in HPV independent. That common types in HPV associated are the squamous cell carcinoma, usual adenocarcinoma, adenosquamous, and small cell and neuroendocrine, while here in independent, there will be gastric type of adenocarcinoma, clear cell, mesonephric, and large cell. So the HPV independent ones, they have a poor response to standard therapy and they have a worse prognosis. So the implication of this distinction is that the HPV independent cancers, they often require an alternative treatment strategies, while HPV associated cervical cancer, they are largely preventable through vaccination and screening.
Now, PD-L1 expression and their therapeutic implication. So IHC plays a critical role in diagnosis and prognostication. So PD-L1 expression and hormone receptor testing is particularly important in specific histologic subtypes. Like if it is a squamous cell carcinoma, which is in most the cases, they are frequently PD-L1 positive. So these are eligible for pembrolizumab in recurrent or metastatic cases. In adenocarcinoma, they can still benefit, but they have a less frequent PD-L1 positivity. While in independent type and independent type, there is limited response to immunotherapy as they are rarely PD-L1 positive. But in neuroendocrine, there can be the immune checkpoint inhibitors and chemotherapy can be used for the treatment. Then hormone receptor testing in cervical cancer, unlike endometrial, they are not hormone driven, but in cancer cells which expresses ER and PR, there is a crucial role in determining the potential responsiveness of the tumor to the hormone therapy. Thus, it can influence the treatment planning and prognosis. Now, the Silva classification, it stratifies the adenocarcinomas into pattern A, B, and C, depending on the diffuse destructive stromal invasion. And the pattern C, they have a high chances of lymph node metastasis, and the treatment is radical hysterectomy with lymphadenectomy and chemotherapy. So diagnosis and evaluation of cervical cancer depends on whether it is a microinvasive disease or a invasive disease. Microinvasive disease, we know that it can be diagnosed during in a specimen, which can be during a cold knife conization, LETs, or trachelectomy or hysterectomy. But the invasion is depth of invasion should not be more than 3 mm or 5 mm in 1A2. For invasive disease, there is a visible lesion, and on punch biopsy, you get a diagnosis of invasive disease. So clinical assessment is first step for allocation of staging. Any imaging modality can be used as per the resources to provide additional information on tumor size, nodal status, local and systemic spread, and MRI is best for assessing the tumors more than 1 centimeters. So the management of stage 1A1 is conization can be done, and it can be considered complete if the entire lesion is included, there is negative margin and no LVSI. Alternatively, extrafacial hysterectomy can be done if childbearing is complete, but if LVSI is present, then we have to add pelvic lymphadenectomy along with extrafacial hysterectomy. For fertility sparing, conization with close follow-up should be done, and any route can be chosen for hysterectomy, abdominal, vaginal, or minimally invasive for early invasive cancers. Then in 1A2, the risk of lymph node metastasis is small, but still it is present, and it will require cervical conization and pelvic lymphadenectomy or radical trachelectomy plus lymphadenectomy. And the post-treatment follow-up in cases of fertility sparing surgery will be 3 to 4 monthly pap smears for 2 years, then 6 monthly for next 3 years. With normal follow-up at 5 years, the patient can return to routine screening is scheduled according to national guidelines. So these are the types of the hysterectomies that are done for stages 1B1, 1B2, and 2A2. Colomoro classification is commonly used, where it is divided into type A, type B, and type C. So type C is basically for stage 1B, B2, and selected stage 2, where uterus and cervix are removed, vaginal margin upper 1/4 or 1/3 is removed, and the ureter is traced to tunnel through the broad ligament, and the cardinal ligaments are divided at side walls, and uterosacral at the sacral region. When coming to the management of 1B1, there is low risk of stromal invasion and in less than 50% with no suspicious lymph nodes. So modified radical hysterectomy can be done, but pelvic nerve sparing surgery is the standard recommendation because it will not only have a post-operative implications, because if there are radical curabilities maintained and intrapelvic injury is not done to the autonomic nerves, so there will be no impairment in urination and defecation. Study findings from SHAPE and CONSERVE trial, they also suggest that conservative surgical approaches may be feasible option for selected patients with early stage low risk cervical cancer. Then fertility sparing strategies, we know that conization and radical trachelectomy can be done, which can be done by open, abdominal, vaginal, or minimal invasive approach. While when vaginal approach is planned, pelvic lymph nodes are first to be removed laparoscopically and examined via frozen to proceed for before proceeding with radical vaginal trachelectomy. In stage 1B2 and 2A1, type C radical hysterectomy with pelvic lymphadenectomy can be done. And advantage is precise pathologic staging, identifying radiotherapy-resistant tumor, and ovarian preservation can be done. There is a role of sentinel lymph node in cervical cancer is increasing acceptance in early stage cases, and dual labeling by blue dye or radiocolloid increases the accuracy of sentinel lymph node. Then in stage 1B3 and 2A2, concurrent CCRT is preferred over surgery. Why? Because adjuvant radiotherapy increases morbidity, and CCRT, there is a better overall survival, progression-free survival. And stage 2B to 4A, external pelvic radiation and intracavitary brachytherapy can be given, and patients with stage 4A disease may have only central disease without involvement up to pelvic side wall or distant spread. So such cases, or in cases of recurrence, pelvic exentration can be considered, but usually has a poor prognosis. So radiation, besides have a curative role, can be used in adjuvant therapy for operated patients. So in stages 1A, B1, B2, and 2A1, although surgery is preferred for early stage, in cases where there is a contraindication, radiotherapy provides equally good results. The treatment decision should be based on clinical, anatomic, and social factors, and the patients with microinvasive disease who have been treated with ICRT alone with good results if surgery is contraindicated owing to medical problems. So adjuvant radiotherapy can be given after a radical hysterectomy, that is post-operative radiotherapy with or without chemotherapy, in patients with adverse pathologic, like they have a high-risk disease, they have a positive surgical margins or lymph node metastasis or parametral spread, or they have an intermediate risk, then they will require post-operative radiotherapy, and no chemotherapy should be offered to these patients. In low risk, no adjuvant therapy is required. So the role of vaginal boost after EBRT is not clear. However, it may be considered for patients who have close or positive margin, large or deeply invasive tumors, parametral or vaginal involvement, or extensive LVSI. So vaginal brachytherapy usually delivered by ovoids or cylinder to upper 1/3. Then radiation therapy for 1B3 and A2, although it is feasible, surgery as an initial treatment is not encouraged for these patients, because often they will require a post-operative radiotherapy or CCRT. So it is well known that the addition of adjuvant radiotherapy to surgery increases the morbidity. In cases of stage 2B and 4A, CCRT is considered the standard treatment for patients with locally advanced based on the result of large randomized trials. Immunotherapy, Keynote 18, we all know that it was a phase 3 randomized double-blind placebo trial, which evaluated the role of pembrolizumab in locally advanced cases, and the primary endpoint was progression-free survival. Though the authors concluded that addition of this pembrolizumab to CRT significantly improves the progression-free survival and overall survival in these high-risk, locally advanced cases. So the post-treatment follow-up should be 3 to 4 monthly for 2 years, 6 monthly for next 3 years, then annually. And at each visit, it is very important to take a history and do a physical examination, screen for complication, and assess for recurrent disease. For recurrent disease, if it is a local pelvic recurrence, then it depends upon the patient's performance status, site, and extent of recurrence. And
Ma'am, your time is up, ma'am.
okay, but just two,
Okay, ma'am.
just 2 slides. So after primary surgery in isolated pelvic failure, radical chemoradiation can be given, or pelvic exentration if possible. If there is periodic and distant metastasis, then if there is an isolated recurrence, then curative intent RT or CCRT can be given. Or if there is extensive local or distant metastasis, palliative therapy can with best supportive care, and chemotherapy options includes platinum doublet chemotherapy, and the interval to relapse, if it is less than 12 months, then clinical trial enrollment for other immunotherapy can be considered. For palliative and supportive care, focus should be on symptom control and quality of life. So a multidisciplinary team approach is required for palliative and supportive care. Psychological support and a tiered approach for pain like morphine assess is essential. Then palliative radiotherapy can be considered for symptom relief, and especially for intractable vaginal bleeding, short course EBRT is can be given for first attempt. And ICRT is highly effective if EBRT fails. So benefit is rapid symptom relief, minimal side effect, and improves the quality of life. So the key takeaways are HPV is necessary cause of cervical cancer. Prevention includes vaccination plus screening is key to elimination. Histology is very important to know whether it is HPV associated or independent, as they have different prognosis. Stage 1A and 1B1 surgery is preferred. In 1B3 to A2 CCRT is preferred treatment. For recurrent disease, a multidisciplinary approach is needed, and immunotherapy pembrolizumab is now standard with CCRT for locally advanced cervical cancer. And for palliative care, it is essential for advanced and incurable disease. Thank you. I think it was very exhaustive.
Yeah.
Because
So
I got
thank you.
very little time to prepare this.
Thank you, Jyoti. I think first of all, I would like to thank ICOG for giving me this opportunity to be part of this program. And this topic, the cervical cancer update by our very own Dr. Nirja Batla, Dr. D.N. Sharma also is here. It is a matter of pride for all of us. And I've gone through the document. It is really exhaustive. One can read it and learn every part, every aspect of cervical cancer. And you have beautifully covered it in this small time that is there and given the takeaways. For residents, fellows, or even faculty, for everybody, it is a great document. And certain newer things like the vaccine update, then the conservative and tailored surgery according to the stage, that is the lesson that we learn as we have evolved over time. And the role of immunotherapy, hormone therapy, testings, PD-L1 and all, these are the newer updates that we get from that. So thank you very much, Jyoti, for giving us this update here. And I'm sure everybody can read that. It is online, it is free. Everybody can read this document for further details. Thank you.
Thank you, ma'am. Thank you, Aisil.
Thank you, ma'am. With this, we move on to our next topic, that is types of surgeries for CA cervix. And for this, I invite the speaker, Dr. Rama Joshi. Ma'am is Chairman, Gynae-Oncology Robotic Surgery, Fortis Memorial Research Institute, Gurgaon, and Chairperson, Robotic Surgeon Council, Fortis Healthcare. Welcome, ma'am.
Thank you. So I think upfront, I would like to thank AICOG and respected Madam Usha Saraya. I'm able to see her very well here. And I think I remember my good friend, I think, Sarita Saraya. And also thanks to Dr. Sarita for giving us this opportunity. Of course, I must say Sarita Square is here. So Sarita Shamsundar. I think she had been taking the very active lead in organizing so much of the academics for all of us. So with this, I start with this share of the screen. Can you all see this?
Yes, ma'am.
Okay, fine. So I think I was very fortunate to hear about actually some sort of the management of the patients, even if the pre-malignant conditions. It was a wonderful talk by Dr. Sarita Shamsundar. And following this, of course, I heard Dr. Jyoti. She has, in fact, covered up almost all. What I'm just going to give you and make it a little more practical, or maybe from the point of view of the surgical aspect. And of course, we are all concerned about the burden of the disease, and it is the Cervical Cancer Elimination Month, and that's how we will all be looking at that, how best we can achieve it. Prevention is one part of it, definitely, but the definite treatment and also the management, of course, it depends on number of situations, as we all understand. We do take care of this FIGO staging 2018, and I think very much summarize that what are the changes in comparison to that of the previous FIGO 2009, and this is 2018. And I think it is just a matter of some sort of, you can say, the focus and the concern, that why we are all concerned about it. When we are focusing on the surgical management of early stage cervical cancer, we are looking at whether it is micro-invasive or it is a gross disease, which we label it as whether it is 1B 1 disease or 1B2. I'm concerned here about 2018 FIGO classification or FIGO staging as such, we can say. And of course, surgery plays a very, very important role. We all understand. And with this, I think let's go on to what are the surgical options and how do we actually choose these strategies. This is the microscopic picture. I think it's very, very popular. Once we are looking at the suspicious microinvasive cancer, we are very much considering how to proceed and what basically to consider. It's very important for us to understand that ultimately it is the final histology of whatever the kind of the surgical treatment we are giving to these patients, where these are microinvasive cancers. And it is important to understand the value of the negative margins that has to be 3 millimeters. So of course, the choice of the treatment, it depends on your colposcopic finding. One can see how much of the normal, you can say the cervix, one can really include, and how deep one is expected to go. And based on that, of course, totally depends on whether it is the fertility preservation or it is not fertility preservation. In those situations, the treatment may vary, but so far as the primary, you can say the management that remains the same. We cannot define microinvasive cervical cancer until unless we go for total, you can say, the excision of the entire abnormal area with that of the proper margins. This is where you can say in this picture, that's how we can define that this is how we are going to do the conization. Of course, it is done under the evaluation on the colposcopy so that we are very sure that whatever the margin we take, that is very, very clear. But at the same time, it is very important that how basically we are going to label it, assess it. You can have maybe the 4 markings or whatever the way, but here you can see these 4 threads. This is just to stabilize the specimen, what you are going to take out at the 12 o'clock, at 6 o'clock, and 3 and 9 o'clock, so that you can really very much can control how much the depth it is going to be and how you are going to be looking at this specimen. So cone biopsy, this is how it is very important. Of course, one can go for, I think there was a discussion and it was also said that it can definitely be the leap, of course, can be the leap. But we should understand that whenever we are taking leap, it's a cautery. So there is going to be a cautery artifact at the margin. So if it is diagnostic or otherwise, I think the cold knife conization is superb. But if it's a very small lesion where you can still have the negative margins beyond your cautery effect, of course, you can definitely go for the leap as well. So these are the surgical procedures which starts from the microinvasive. And definitely we have to look at, if it is stage 1A1 disease, what is important is that you have to assess the LVSI. If LVSI is negative or LVSI positive, that is going to make a difference in assessing, or rather in actually addressing the draining lymph nodes. We all understand that most of the lymph nodes in cervical cancer, of course, it's very much stepwise. Of the progression of the involvement is stepwise. So that is going to be the pelvic lymph node. And the most common is obturator. We all understand. Can be internal iliac. External iliac is comparatively much, much less. Sometimes it can be the low, you can say the common iliac lymph nodes, which can also be affected in such situations. So there is a role of the sentinel lymph node mapping in these situations. So smaller is the lesion, more are the chances of knowing the status of the node. What are we doing here? We are addressing the primary site along with that of the suspicious node. That is, sentinel node is the node which is first affected. in a way that is first drained out of the cervix on both the sides. And of course, algorithms and all required to be followed. Similarly, based on the invasion of the micro invasion, if it is more than 3 millimeters, but less than 5 millimeters, this is what is about A2 disease. But of course, we have to address here sentinel node almost in all the patients. And that's how we can go for. But once it is the you can say you're putting the speculum and you see that this is what is the lesion that's on the cervix. And it is important for us to, of course, to have the proper biopsy. We know that it is the keratinizing squamous cell carcinoma. Once it is labeled on histopathology, the question comes, what kind of the surgical treatment we offer? I'll just focus only on the surgery. So basically, that's how we are just looking at. It had been the standard of care, type 3 radical hysterectomy with pelvic lymphadenectomy, or the radical radiation therapy. Of course, we do understand. Focusing onto the extent of the surgery is very, very important. We have become wiser over the period of time in order to go for the good selection of the cases based on the size of the lesion. Smaller is the size, how optimally we can decide what all we require to do. Why it is so? Because we can give the morbidity, we can really control the morbidity of these patients by not giving them very extra radicality, but at the same time, not compromising with that of the oncological outcome. We do face the problem of the fertility preservation. So we have to be selective when to do, when not to do. I think Dr. Jyoti has really made a very good explanation on even the fertility preserving surgeries for cervical cancer. So it is the appropriate management, which is very important. That is true so far as even the radicality is concerned. So smaller is the lesion. Of course, the radicality can be comparatively optimal. And it has been seen over the period of number of years and the kind of experience which we had, even shorter. And also, I think I remember Daniel Dargent here. He used to do actually the kind of the radical surgeries and basically had pointed out smaller is the lesion, less parametrial excision is required. But if the lesion is comparatively large, one has to do the excision of almost complete parametrium right at that of the lateral pelvic wall. So whenever we are doing surgery, and also maybe the type 1 hysterectomy, if suppose we are considering, what is important is the fascia which is surrounding the cervix. That has to be included with the cervix. So please understand that the clamp is going to be by the side of the cervix laterally, not on the cervix. It's very much practical aspect which I'm just sharing about. Whenever it is type 1 decided, if it is microinvasive, going for the type 1 hysterectomy, that's how this is the type 1. And when we are removing the medial parametrium, means medial parametrium, till you can say what is the landmark for deciding these. I think this is better explained, I think, little later. So this is how we decide whether tumor size is less than 2 centimeters or between 2 to 4. But if it is more than 2 centimeters, more than 4 centimeters, we don't like to take these patients up for surgery. Of course, in these cases, we are further choosy in selecting our patients for the fertility preserving surgery. And that is how it makes a lot of difference, because we are concerned about the cure rates and the comparative studies and comparative evidence when it suggests that the cure rates are similar, but the morbidity is less. That's how we become wiser. That's how fertility sparing options, you can say surgery, how we choose it, that what we are supposed to do. Microinvasive, we can go for the conization. Of course, this is the extent of the cone biopsy, always. Then followed by the trachelectomy, simple trachelectomy. Sometimes you find even the microinvasive lesion, which is covering the entire cervix. Of course, you have to modify. And also going for that of the radical trachelectomy, maybe in the form of, most of the time when we are doing vaginal, this is what the medial parametrium we get, but the extent can be really increased in that of the abdominal radical trachelectomy. Majority of the time, this is what we go for, the medial parametrial, because the size of the lesion chosen for the fertility sparing is less than 2 centimeters. That's how we can offer them the best. And this is how the trachelectomy specimen looks like. You have taken out the vaginal fornix, means almost say 2 centimeters of the vagina, and the medial parametrium. That's how we can really assess it. And the evidence have suggested that, of course, the oncological outcome is quite similar. And that's how we have become wiser. Even there have been the comparisons of the vaginal trachelectomy and abdominal trachelectomy, of course, looking into even the pregnancy rates and also the recurrence rates. Recurrence rate is has not been found to be significantly different. We do not have level 1 evidence. So with this, I think I have one surgical video, and with the permission of the chair, that's how we are going to give me 5 minutes for that. And this is what we can say, that this is type B1 and this is type C1, where we are sparing the nerves. The nerves are spared, that is type C1 hysterectomy. But whatever the video I'm going to show, that is of type C2 radical hysterectomy. So that's how we have basically, I think I just would like to take it here sometime. So as soon as we open, I just want to show you this, that feel for the parametrium, that the parametrium should be normal. And after that, of course, in this kind of a video, I have gone for the pelvic lymphadenectomy first, and then we had gone for the radical hysterectomy. Sorry. So what you can see here after the developing the spaces, that's how you can see that the uterines, these are tight at their origin. And that is after developing the paravesical and pararectal spaces. Sometimes you do require to go the best way possible. And after developing the spaces, and this is what is the utrovesical fold of peritoneum. This is right at that place where it definitely folds onto the bladder. So this dissection is done in the cervicovesical space. And to be more clear, see, this is how you can see that the space is created anteriorly. And we can see here that these are the two spaces. One is here is the dissection of the ureter from that of the lateral peritoneum. And this is where the ureter enters. And this is where we basically enter into, or rather resect the parametrium right at that of the lateral pelvic wall. That is lateral to the ureter, but at the level of the lateral pelvic wall. And after dissecting the pelvic. But this is the video of the open surgery. So it may be little, I think, the movement may be there in the recording. That's how the parametrium is excised here, right at that of the lateral pelvic wall. So whatever the dissection we do, it is important that all the surrounding parametrium is excised. And this is where the ureter is entering into the parametrial tunnel here. Anteriorly, you see is the paravesical space. Posteriorly is the pararectal space. And
Ma'am, your time is up.
okay,
Okay, ma'am.
all right, fine. So I think that's how we can do the radical hysterectomy. And after dissecting, if you want, that this is what is the dissection into the parametrial tunnel. And we excise this completely. This is the parametrial tunnel, which you open up, and that is excised along with that of the specimen. And this is the paravaginal excision. This is finally, you can see the anatomy, pelvic anatomy, where there is unification of both the spaces. With this, I thank you all for the opportunity. And this is done. So this is the ultimate specimen. Our final concern is that that's how we go about. We complete this, and then I think I stop sharing. We
So,
go for the final histopathology and then the adjuvant treatment.
so good evening,
Thank
one
you.
and all. So, good evening, one and all. At the outset, I'm thankful to the organizers, especially ICOG and the entire organizing team for giving me the opportunity to chair the session. Along with that, coming to the speaker, she's always the best. No doubt, Dr. Rama Joshi, madam, we have heard from years together, and today he has described so nicely all the steps of hysterectomy and the stepwise management. Along with that, with special importance to the fertility preserving surgeries. So where to do for tracheotomy, what kind of abdominal route, vaginal route, everything she has described very nicely. Along with that, he has a nice video also. Due to sort of time, not able to play completely. Anyway, she has described. Thanks, Rama madam, for the nice presentation. Thank you. And over to this organizer.
Thank you, ma'am, for the wonderful presentation and excellent video. It was very useful to all the participants. With this, I move on to the last lecture of the session, that is on radiation therapy for cancer cervix. I would like to invite our speaker, Dr. D.N. Sharma sir. Sir is Professor Radiation Oncology, All India Institute of Medical Sciences, and presently working as Director at AIMS Rewari, Haryana. Over to you, sir.
Thank you very much. Can you see my slides, by the way?
Yes, sir.
Okay. So, respected chairpersons, ladies and gentlemen, very good evening, and thank you, ICOG Foxy, for inviting me. And the topic given to me is the radiation therapy for cancer cervix, whom and how. And since it is a teaching course, I kept my talk very simple and very basic. So it is two portions. The talk has two components. First is that whom to refer for radiation treatment for the cervical cancer. And I would say everyone, because the radiation treatment is the treatment choice for all stages, right from stage 1 to stage 4, radiation is effective. And about 70% patients present in advanced stage in India. That means they are non-surgical patients, and about 60% of the patients who are operated, they require the adjuvant radiation treatment. And therefore, RT remains the principal treatment of modality in majority of the patients. And as a surgeon, you must be familiar with the radiation treatment. You must know the ABC of the radiation treatment, even though you need not practice it. For the ease of the treatment, I divided the carcinoma cervix into 4 categories. First is the early stage cervical cancer, then the locally advanced cervical cancer, then the metastatic disease, and the recurrent disease. And radiation has the role in different settings. First, as a definitive treatment, where patients are treated just by radiation and chemotherapy and no surgery. And the second category is the when the patients are treated by post-operative radiation treatment after the surgery, if they have some adverse features. And if the patient has a incurable disease, then we can treat the patient by palliative radiation treatment, which is very, very effective. For early stage disease, we can offer surgery and radiation both. Both are equally effective, and there are no data supporting either one as a favorite treatment. But usually surgery is kept for the younger patients and who are sexually active, and radiation is kept for patients who are elderly patients. But in the institution, you should decide the treatment modality for early stage cervical cancer based on the following factors. Surgery, as I said, is kept for patients who are young and not suitable for chemotherapy, patients having adenocarcinoma histology, and other factors like associated uterine pathology like pyometra or the fibroids. And the centers where there are no facilities for brachytherapy, they are also preferred for the surgery. And patients who are medically inoperable, imaging showing the pelvic lymphadenopathy, and they are likely to receive post-operative, so they should also be treated by chemoradiation. Patients who are postmenopausal and patients having the borderline parametrium positive on imaging, so they should be treated better by the chemoradiation treatment. Then second category is the adjuvant treatment, which is the radiation treatment after the surgery for patients having the adverse features. And usually chemotherapy is combined for patients who are having pelvic nodes positive, parametrial invasion positive, or the positive surgical margins, and patients who have undergone incomplete surgery or inadvertent hysterectomy. These patients are treated with the post-operative chemoradiotherapy together. And the patients who have just any two of the three features like bulky uterus, more than 4 centimeters, bulky tumor, sorry, and the deep stromal invasion or the lymphovascular invasion. So any patient having two of the three features would require the post-operative alone, and patients without all these features will not require any adjuvant treatment. Now coming on to the carcinoma cervix 1B2, which is now 1B3 as per the latest FIGO staging. And this has been a little gray area where the surgery in RT has been practiced, but the trial so far has shown the equivalent survival rates. And there are not many randomized trials except that one trial. And if you choose surgery, you must remember that 60 to 70% of these patients will need post-operative radiotherapy. So therefore, you will be combining the side effects of both surgery and radiation together. Morbidity is higher when we combine surgery and post-operative. It goes from 14% to 28%. And therefore, surgery should be avoided if we anticipate that RT is required for these kind of patients. And therefore, for 1B3, the standard treatment is, of course, the chemoradiation nowadays. Now, coming on to the locally advanced cervical cancer, the most patients present in advanced stage in India, as I had already elaborated, concurrent chemoradiotherapy is the standard of care for these patients. There are no doubts. There are not many confusions here in this stage, locally advanced cervical cancer. Results are, of course, relatively poorer as compared to early stages. And neoadjuvant chemotherapy has been tried in many trials, but so far there has been no success. And therefore, the treatment of these locally advanced cervical cancer is concurrent chemoradiotherapy. Then the second part of the talk is that cervical, how to treat by radiation treatment, radiation therapy for the patients having the cervical cancer. And this is typically done by the combining the external beam radiation treatment plus the brachytherapy, which is called the intracavitary radiotherapy. And external beam radiotherapy is preferred by IMRT or four-field on the linear accelerator. Cobalt is not a preferred machine nowadays. Never treat a cervical cancer without the brachytherapy, as the treatment is incomplete without brachytherapy. The prescribed dose of radiation together and combined by EBRT and brachy should be around 80 to 90 grade to point A, or nowadays to high risk CTV, which is clinical target volume. Point A is disappearing from the practice because now we do the image guided brachytherapy. So therefore we prescribe the dose to the high risk CTV. The dose should never be less than 80 gray. And if intracavitary brachy is not feasible or available, then perform another form of brachytherapy, but never replace this with the external beam treatment. Treatments will complete within 8 weeks. That is one important parameter we have to remember. This is just to show that how the EBRT and brachy and chemo are combined together. In the first phase, we give the external beam treatment on LINAC, and every week we give cisplatin chemotherapy. And then after the EBRT is over, then we give the boost to the primary tumor and the medial parametria with the help of intracavitary radiotherapy, we typically give 7 gray times 3. That means every week patient receives the intracavitary radiotherapy. And this just to show how what we treat on EBR treatment and what we treat by brachytherapy. As you can see in the left hand side, on EBRT we treat the central disease, the uterus, the parametria, the pelvic nodes. A laser field is treating the disease, and then we give the brachytherapy to boost the primary tumor, which is the hub of the disease, and therefore we cover all the areas to be treated. This is the dose schedule we follow at AIMS. We first give the external therapy by a dose of 50.4 gray in 28 fraction over 5.5 weeks. And this is followed by after a week by intracavitary brachytherapy with a dose of 7 gray times 3. Every week we perform this brachytherapy. The treatment volume encompasses the central disease, the uterus, vagina, parametria, pelvic nodes, and in certain cases, parietic nodes. This is exactly what we treat by the surgery. So the principles of treatment do not change whether we treat by surgery or radiation treatment. And this is what we treat by radiation treatment. As you can see, the red color showing the target volume to be treated by the radiation treatment. And few years back, we used to treat by the four-field technique, which means by giving two lateral portals and one anterior and one posterior. So by four-field, but with this field, the part of the bladder, in fact, major part of the bladder used to be treated along with the rectum. Of course, it used to cover the disease. So therefore, there were a lot of side effects because of the signal dose delivered to the rectum and the bladder. But off late, we have the IMRT, which is called intensity modulation radiation therapy, where we can treat the required areas at the target volume and minus the bladder and minus the rectum. And if you can see, we can minus even the gut also. So this is done with the help of the IMRT, where we delineate the part to be treated and we delineate the part not to be treated. And then after the delineating the disease to be treated and the areas not to be treated, we throw 7 to 9 beams of the radiation beam on the linac from all sides, and then we achieve this kind of distribution. As you can see, we are treating here the central disease, the parametria, the nodes, and minus the bladder and minus the rectum. So this is what we can achieve by using the intensity modulus radiation therapy. This is called intracavitary brachytherapy, where central tendon is inserted into the uterus and the two ovoids inserted into the vagina. And this is what we get. We treat the central part of the disease minus the bladder and minus the rectum. Again, it is done by the image guided brachytherapy. And nowadays, we prefer the MR guided brachytherapy, where rather than prescribing point A, we prescribe to the disease evident on the MR. Although due to the practical limitations and the logistic problems, we're still using CT, which is equally good. Patients where the ICRT is not feasible due to some reason, then either because of fibroid or because of non-negotiable os or because of the parameter involvement, we treat these patients by interstitial brachytherapy with the help of the template. And in this, we apply template on the perineum, and then we insert the multiple stainless steel needles into the pelvis, covering the primary disease and the parametria. And this is how the perineal template brachytherapy looks like, where there's a template, and then we are using the multiple needles to cover the disease person. And then we do imaging, where we again delineate the area to be treated. As you can see, the different multiple needles covering the primary area and the part of the parametria. And then we delineate the bladder and the rectum. And then we create a dosimetry on the computerized treatment planning system. As you can see, a bladder, the rectum, and the area to be treated. And this is how we generate the dosimetry. And as you can see, the bladder, in fact, you can see the urethra. So we can measure the dose to the target area, which is in the red color. And then we can measure the dose to the bladder, even urethra, and to the rectum. And therefore, we can avoid these structures and we can treat only the disease which is to be treated. So finally, to conclude, radiotherapy remains the treatment choice for the carcinoma cervix. It is a principal treatment modality in countries like Asian countries. Concurrent CTRT is the standard of care, and we usually combine the external radiation treatment and the intracavitary brachytherapy in order to achieve the tumoricidal doses of 80 to 90 gray. Modern radiotherapy is very safe, accurate, and very precise, unlike the treatment which was 15 years back. The toxicity is quite minimal, and the local control is improved because of the use of the IMRT and the chemotherapy. Imaging and computer technology is very vital in today's radiation treatment, and every patient of carcinoma cervix should be evaluated together in the joint clinic. That is how we treat the carcinoma cervix nowadays together. Thank you very much. I think I finished in time.
Yes, sir, you're very, very much in time and very clear presentation.
I am the
Thank
last
you
speaker,
so
so I
much.
had to. I
No,
had
there's
to.
still a lot of them are still logged in, so that means they were very interested in to listening to your
Right,
talk.
ma'am. Right, ma'am. Thank you, ma'am.
Yeah, so I request the chairpersons to give their comments.
Thank you, Professor Sharma, for elaborate
Thank you,
presentation of
sir.
the radiotherapy. And
Thank you, sir.
I'm nothing to summarize here because he is the matter of the radiotherapy.
Sir.
Only thing for others to know that
Sir.
RT can be primary and primary and adjuvant, and primary is
Yep.
for all the stages, and adjuvant is for
Yes.
few. This is stage when we are operated, or and
Right, sir.
we find in a intermediate risk group or in a high risk group. So intermediate risk group we give only radiotherapy without chemotherapy, and high risk group we have to give concurrent chemoradiation. That is the only, and in all CSRBs, one should use at least brachytherapy. Otherwise, it is
Yes,
the
sir.
treatment is incomplete. That is
Thank
the
you, Dr.
only
Giri,
summary
sir.
for what I can do. And now
Thank you, sir.
ICRT, IGRT, all things are coming up, and Dr. Sharma is the best person to do. And
Sir.
we have selected to deliver this talk. Thank you very much
Thank
for
you,
your
sir.
nice presentation. Thank you.
Thank you, Dr. Giri, sir. Thank you very much, sir.
Thank you. Thank you.
So we thank all the speakers for the excellent talks and also the chairpersons for giving their valuable time and their comments. So yes, for the
Shall I share
post-test.
the link?
Yes, please.
Yeah.
And meanwhile, the ICOG team, there are requests to show the video. So if there is time, can we show any, about 5 to 10 minutes? If we show the video of some procedure, the people are asking. So after the post-test, you tell me if we need to. Oh no, this is the CV. Okay. So you can scan the QR code or even click the link in the chat box for the test. Please click on the QR code and or on the link to the Google form with your phone to scan with your phone. Just scan the QR code with your phone, the camera, phone camera. Or just click on the link which is in the chat box. So that takes you to the Google form which has the test. Nilima, can you post the QR code?
Ma'am, I have shared the QR code via presentation. So they just have to scan via camera or yeah.
So we'll just wait till they do it. 15 minutes? Or should we start the answers? So tech team, they have most of them have done the test. So we'll go with the over the answers. We can project the answers. Hmm. Okay. Okay, so the first question is a 55-year-old postmenopausal woman who has had a pap smear that the report is atypical glandular cells of undetermined significance. So select the management option from the following list that is the most appropriate next step in the treatment. So this is the answer is perform colposcopy, endometrial biopsy and endocervical curettage. Then the second question is choose the incorrect option is the question. So the answer is cryotherapy is effective in TZ3, so that is not effective for type 3 TZ. So following are done to prevent injuries in deep outlets. So either using an insulated speculum. Then number 3, when taking a vertical loop, the loop should go from below upwards and not from above downwards because the bleeding can just obscure your vision. Good contact to monopolar ground plate with the body should be ensured. So all the three options have to be written 1, 3 and 4. So the option C is correct. Now choose the incorrect option. So whether the TZ is being excised or destroyed, treatment to a depth of 4 millimeters is considered optimal. So in an excisional method, the depth goes to more than 4 millimeters. So it can go up to 8 millimeters, 10 millimeters also. So eligibility for ablation is all except. So biopsy should always be available before treatment. So that is not the case, especially for if you're going for screen and treat. Biopsy is not always available. So you can do it without a biopsy also. Next, question number 6, which is not true for IFCPC terminology 2011 for description of the lead specimen. The answer is height of the cone lesion is the length of the endocervical canal excised. That is the not true. So length is the distance between the endocervical to the ectocervical margin, thickness of the specimen. So all these things are correct except for this, except for 2. Then number 7, the inclusion of male vaccination program is primarily aimed at reducing and the HPV related anogenital cancers and transmission. The B is the answer. Now coming to question number 8, the WHO now endorses which vaccination, HPV vaccination schedule. So it's either 1 or 2 doses depending on the age. So it is less than 15, it is less than 20, it is 1 dose, and after 20, it is 2 doses. So now question number 9, which of the following is an emerging trend in HPV vaccination programs worldwide? So that is a single dose HPV vaccination schedule. So a lot of countries are switching over to single dose because it is cost effective and it is as equally effective. Which of the following vaccines, the question number 10, provides the broadest protection against HPV types? So it is the nonavalent vaccine because it covers 9 HPV types. Question number 11, the primary purpose of colposcopy examination is basically to magnify the cervix, vagina and vulva for abnormal areas following an abnormal screening result. So that is to identify the abnormal areas and select what is the type of treatment you can do. Which instrument is commonly used to take tissue sample biopsy from the cervix? The answer is Tischler or Burke punch biopsy forceps. Question number 13, which condition is a contraindication for performing endocervical curettage during a colposcopy? So it is pregnancy because we should not be doing endocervical curettage in pregnancy. Next, question number 14, which is the following is not a common indication for colposcopy. So routinely we don't do colposcopy as a screening test. There are some countries where it is done, but this is not because it's not cost effective to do colposcopy for all. How many times should the brush be turned when doing a liquid LBC? So it should be 5 times and clockwise. If you do anti-clockwise, then you will not get a proper sample. Question number 16, what is the recommended age to start cervical screening by WHO and FOXI guidelines? It is 25 years with the pap smear. With the HPV, it is 30 years. So the recommended age to start screening is 25 years if you're doing by the pap smear. For women aged 30 to 65 years, which is the screening option recommended by the WHO, it is HPV test alone every 5 years. Not co-test because that's not found to be effective, cost effective. Question number 18, at what age can cervical screening be stopped? Just scroll down. Yeah. At what age can cervical screening be stopped if the woman has had adequate margins prior to the test? So it is 65 years. So 65 only if prior screenings are normal. Which stage of cervical cancer most commonly requires concurrent chemoradiation as the standard of care? So it is commonly they come in this stage, that is stage 2B. Scroll down. Which form of radiotherapy is a standard treatment for locally advanced cervical cancer? So it is EBRT combined with ICRT. So external beam along with brachytherapy is to be given. That's it. That's all the 20 questions. So let's see what are the questions that you have. Question number 16. What is the 16? Okay, question number 4 and 16. Can you just project again? And question number 5. 4, 5 and 16. Question number 16. The recommended age to start screening, where the start screening you start at 25 because you can start with using a pap smear. For HPV it is 30 years. Okay, now going to let's go up to question number 4 and 5. 4 and 5. Choose the incorrect option, whether the TZ is excised or destroyed to. See, if it's excision, it is you go deeper, isn't it? Whereas for ablation, it is enough. For 4 millimeters is enough. But for excision, the depth of the 4 millimeters is very superficial. And question number 5 should always be available, not necessarily before doing an ablative treatment. You don't need a biopsy before doing an ablative treatment. It is good if you can have a biopsy, but it is not mandatory. So I think how to see the score, that's the ICOG will tell you this. You will get it at the end of, because it's over 3 days. It's not just one day. It's over 3 days. So you'll need to do this or attend and do the test for all the 3 days. Only then you'll get your certificate. So thank you ICOG team, and thank you to all the speakers, to the chairpersons, and to all the delegates for attending and also for the excellent interaction. Okay, there's still more messages. Recommended method by WHO is HPV testing. It is that is the next question. It is the HPV test.